I'm Sandy Kuehn. I have the awesome privilege of being the CEO here at the Center for Addiction Treatment, or the CAT House, as most people know it affectionately. I want to welcome you to our newer facility. We've been in about 18 months now. This particular building is all outpatient. So we have our big medication-assisted treatment program here next door. We have about 450 patients in there every month. We served 720 unique individuals in that last year. Also, we have mental health counseling, which is what we call the lower level instead of the basement. And that's a new service for us. We just started that about a year ago. And I'm really happy that we're not only able to do group counseling and individual counseling on the mental health side, but this gives us the ability to treat couples and families, which we've not been able to do before. And you know this is a family disease, and so that was a piece of the puzzle that we were not able to provide to our patients at that time. So we do now. In addition to that, we've opened a primary care clinic, which we call Monarch, which is right as you come in the front door. It's for adults, any adult. We specifically look for people who have a diagnosis of addiction, because our patients tend to have a lot of, at least less now, but a lot of medical prejudice when they show up at primary care facilities seeking help for a primary care issue. So we wanted to be able to provide a whole integrated approach to addiction and mental health, to behavioral health. So we've been able to accomplish that. In addition, the historic services that CAT's provided are detox and residential treatment. We still do those. Those are next door in what we now call CAT's Classic, because we didn't want the old girl to feel neglected. We just call her the old building, so now she's CAT Classic. We're doing some renovations over there. When we're finished in about 6 months, we'll be able to add 15 detox beds, specifically set for women. So we'll go from a total of 60 beds to 75 beds here on this campus. We also have some other ideas percolating, so we may end up with a third building on the campus, fitting another need we know is in the community, and that's for transitional housing, particularly for people who are on medication-assisted treatment. So there's a real need in the community for that piece. Of course, that will take a while to get done, just like everything else does. But we're really proud here of the 50 years of service that we've had in this community. We're blessed to have lots of partners who help us in this process, including the EMTs who end up showing here not as often as they used to, since we have our own physician and 2 nurse practitioners here, but they've always been a very great partner to help us with patients with issues that we can't accommodate here. So we're glad you're here. We're happy to be a part of this process, and know you'll learn a lot of things today that hopefully you didn't know before. But thank you, Larry. Appreciate it.
It's an honor to be here. And the first Sunday of each month, I have the honor of being here with my 3-year-old Labrador Retriever, and meeting with patients who are in for 28 days. And a couple of months ago, I had a sobering experience. A young lady came over and said, "Can I get off my chair and sit with your dog and hug him?" And she's hugging my dog, and the dog's hugging back. And she says, "I'm so anxious to get home to see my 2 children in Madeira." It was one of my neighbors. And 2 Sundays ago, I'm back with Fry, and we have about 20 men and women in chairs. And one of the young men says, "Professor Bennett, what are you doing here?" And I in turn said, "What are you doing here?" And he said, "My fire department allowed me to resign." Sobering. Career ending, potentially. So thank you for what you did. And my dog loves coming. He gets lots of hugs and kisses. So Amy, come on up. We're honored to have you. I turned on the TV yesterday, and all I'm seeing is a pretty face talking about innovative things happening in Hamilton County. So you share.
Thank you so much. So I'm Amy Murray, and I'm on Cincinnati City Council. I am Vice Chair of our Law and Public Safety Committee. So thank you for being here. Anyone that's not from the city, welcome to Cincinnati. We have a lot of different things going on in the area of Cat House, so it might have taken you a little while to get here, a few detours, but it's great growth for the city. So happy to have you here. I saw our Fire Chief Winston, who is a great partner with everyone. Sorry if I'm losing it all. I had foot surgery, so if I'm a little off, I apologize. Larry, thank you so much for putting this together. This is so important for our community, and we so appreciate having Cat House here and all that they do. So I'm here to speak about something really exciting that we just launched in the city of Cincinnati on Monday. And so about a year and a half ago, I was at a conference with some other elected officials from around the country, and I was having dinner one night with the mayor of Providence, Rhode Island. We were just talking about what was going on in our cities, and he said they were having a huge issue with the heroin epidemic, and they had started this new type of program called Safe Places. And Manchester, New Hampshire had also, or Safe Stations. And so we got to talking about it, and I just say this because you never know who you're seated next to that says, hey, between this, you might want to think about it. And even if it's out there, you might not have heard about it. And so we spent the next 2 or 3 months talking back and forth, talking with Manchester, New Hampshire, and their fire chief about what they had put together to really help with the addiction crisis, the opioid crisis going on in our cities. And it culminated with yesterday with our launch. So through City Council, we looked at the opioid epidemic, heroin. I mean, it impacts everyone that we think about, our neighbors. And it's just heartbreaking for us. So I kept thinking, what can we do as a city? How can we play more of an impact? And part of it was in the greater Cincinnati area, we have treatment facilities. People somehow don't know how to get to them. You know, sometimes it's hard for them in the throes of addiction to be able to get where they need to go. And so we thought if we can present them with another easy, safe place to go to get help, then that might, you know, relieve the firefighters of some of the work that they have to do with overdoses. If we can get people when they're ready to get off of their addiction, off of opioids, heroin. So what we've put together is we have Safe Places Cincinnati. We have 7 health centers. Other places, they use the fire stations, and we might also progress to that. We've been in talks with our fire stations also, but we wanted to do a pilot program on this because it hasn't been done in a city this size. So we have trained our staff within the healthcare facility, and if someone all of a sudden they're in the streets of Cincinnati and says, I am done, I've been thinking I'm done, where do I go? You know, often they don't have family there that can help them. You can get to Cat House, but you know, if you walk here, how do you get here? So you can go to any one of our health centers, and we have a Safe Place Cincy sign there, and you can walk in and say, I'm here for Safe Place Cincy. And we have a strike team in each of our health centers located, and they're already there. They do other jobs, so we haven't added more personnel, but they are there when someone comes in and says, I'm here for Safe Places Cincy. And we don't want it to be a stigma. We don't want it to be, you know, we don't want it to be anything except a soft handoff where they are welcomed in, and we have people there that will triage them and find out what their needs are, what their concerns are. If there's some big issue, then we will transport them to an emergency room. But if not, they will talk to them. And we have 3 partners that we have partnered with for our pilot program: Cat House, Brightview, and Talbert House. And we wanted to keep this small so that we could really know exactly what is happening and how we can improve the program as we go forward and how we're serving people. So our teams at the health centers have been working with the providers to put together questions, issues, things like that, so then they can assess the person and say, you know what, I think the best place for you to go to is to Cat House or to Brightview. We're working with providers on a daily basis so we know who has beds. Because, you know, for people, sometimes there's a lot of sources, but who has beds at that time? So we're working to make sure they have beds. Then our strike team at the health centers will call over to one of them and say, we have someone from Safe Places who's going to be coming, do you have room? So that they know to expect them. We are working with Uber Health. And so this is a game changer, because before we had these options, if you had to send them in an ambulance, you can imagine the cost. But with Uber Health, it's maybe $10 to $15 a ride. And this is what Uber Health does. They have this health division. So we have a contract with Uber Health, And we call them and say, we have someone from Safe Places, and they'll be going from this health center to this facility. So Uber Health will come and pick them up. We have a kit that we give them, a goodie bag, if you will, just to get them through until they get to the facility. And then they will go to the facility and they will welcome them as a safe place person and go from there.
That's amazing.
So this is just another way for someone, because we have a lot of people that come into our health centers. A lot of people, we've already, I think since Monday, we've had mornings at 2 people that came in on Monday. We had 2 at the soft start last week, all voluntary. So this isn't something that you can bring someone in. The plan of this program is it's voluntary, where you are saying, I want help right now. In Manchester, New Hampshire, they see about 150 people a day in their fire stations that are coming through safe stations. And of those people, when they have them go to the facility, 100% make it to the facility in Uber. You don't have people jumping out saying, oh, I don't want to do it, because they've come in voluntarily.
Amazing.
There's other programs for people that aren't coming in on their own, but this program is for that reason.
That's great leadership. And could you share a few words about leadership in Cincinnati Fire? How, Roy's here, and he's going to be addressing us next. How did City Council and the fire department move forward with quick response teams?
Yeah, well, and so just on all of this, what we did with this program is because we want to work with everyone in the community, so we worked with Interact for Health. They have been an amazing partner. Early on, we went to them and said, can you help us? We went to our fire chief and said, what can we do to help with this? How can the fire department help us? So we have been partnering all along. And with the fire department, because you have fatigue. You have responder fatigue, especially from overdoses. So anything that we can do to help get people the treatment they need so that you're not going for an overdose. But this is a all city, all department effort.
Do you mind if I open up for a couple of questions?
Absolutely.
All right.
Happy
This
to.
is like a press conference. Go for it. Right? Who are the Uber drivers? Who's going to be signing up to do this?
Well, and that was a concern of ours. Our first thing is how do we get this transportation piece done? Because we're like, how do you do this? And so Uber drivers sign up for Uber Health. And I asked, well, are people going to be concerned because here they're taking someone who is admittedly an addict to a place, are they going to feel safe? And they said, our Uber Health drivers love to do this because they'd rather take someone that is doing something for their health, for their mental health, than taking someone to find their next hit.
Yeah.
Because often they'll have someone that calls and they'll want to go somewhere to get their next hit. But this way, they are taking them to some place where they want to be. So they feel very safe about it. And if you think about it, the cost of an ambulance compared to a $10 or $15 cost of Uber. And Lyft does the same thing. And so, I don't know where we would be without these rideshare companies offering this. And I encourage you, if you're thinking of programs like this, we kept getting scope creep. We kept saying, well, what about, homelessness is a problem? Or what happens about this? Or what happens on that? And we had to stay laser focused. Because it's so easy to get off because there's so many things you want to do. And we kept saying, what is our mission? It's to get people that they can walk into a place anytime. And I say anytime, we're not 24/7 at the health centers, but we're hoping to expand to that at some point if we bring in the fire department, but that people could walk in and get help when they need it. And we got to keep focusing on that. Because as you know, in this area, there's so many other things you want to do. Or let's just stay focused.
Amazing.
I'm sorry, I'm part of the MIT group,
Yes.
medicine after treatment. I was wondering, what is in the bag that you give the patients?
So, this is just, it's water, it's granola bar, it's just, a nice, it's a...
No medication?
No medication,
Okay.
no medication.
That's
It's
what
just
I
something, because if they come off the street, if they haven't had breakfast or lunch, or if they're thirsty or whatever, it's just a bath to get them. Now, we do make sure through the program that they'll make sure that everyone has Narcan, and that we have that covered.
Okay.
Yes.
Question?
Yeah, my name's John. I'm also with the MAT support community. I'm curious what, say if you go to Brighton as outpatient, what kind of follow-up are you guys going to do with these people? So when they go to Brightview, you might not ever see them again, and we might not ever see them again.
So we're working with the providers. As you know, it's really hard because of legality and what you can share. And so our success rate, our thing is to get people to the treatment where they need it, and then we will follow with the treatment center, so they will be using their normal protocols. But we are working really hard so that we can follow it and say people that came in through safe places, X amount. It's hard to tell that they follow a 6-month program.
I think part of the The metrics at this point are sort of those basic things, like did they show up? Did they get assessed? Did they get admitted? How long did they stay? Were they there, depending on the level of care, did they complete that level of care? The data that we would collect anyway, we send it all back to the health department. It went to Interact, who's actually doing the evaluation. So don't tell us basic things. Like, did they get there? Were they admitted? If not, what happened to them after that? And how, were they in treatment at 30 days and 60 days?
Amazing, wow.
And what they've done in some other safe places also is it is the fire station. So in some towns, smaller towns where there's a couple fire stations, they train the fire department and people can walk into a fire department and they have the same program where you get assessed. And they found in Manchester, an average customer is there maybe 15 minutes.
Got it.
So it's not shutting down the fire station for that long.
All right, one more, yes, sir.
Is there any plan to roll out these Uber health services to emergency departments? One of the barriers I find as an emergency physician is that someone comes to the ED, I can induce them on buprenorphine, I can give a warm handoff to Brightview or Talbot, and then they tell me, well, I can't get there tomorrow morning.
And so that's hard because we had to get funding for the Uber, that was the main part of the funding. So that is something that maybe as a community that we need to look at.
So it would be transport from your ED?
No, the next morning.
The next
morning. Got it. Well, I can just see this growing. What an opportunity. Have a round of applause.
Thank you for being
Oh,
here.
my God. Roy, that's a tough act to follow. Come on. This morning at 9 o'clock is a meeting of the Hamilton County Fire Chiefs, so 42 plus chiefs in the room. All right, some of whom are looking at Chief Winston and saying, how are you doing this? What impact is this having on your budget and on your personnel and on your EMS chief? What's the implications to a fire department when you start a quick response team? So you could share a few words.
Well, for us, it was kind of a new thing. We weren't very familiar with how quick response teams actually work. So when we started the program a little over a year ago, we did some research with other fire departments just to kind of see what their best practices were. Right now, we're fortunate we can fund it on overtime. That always helps. It's a great aid. So that funding, we through grants and so forth. So it's not like we're using on-duty personnel. We have almost 900 uniformed members, but we're using our ALF supervisors, who are paramedic lieutenants, to do this on their off day. They do it on Tuesdays and Thursdays. We started on the west side, which back in 17 was where our explosion really occurred, but then it kind of migrated somewhat downtown as well. So our second response team, which goes out on Thursdays, actually occurs in the downtown, a lot of the homeless camps and so forth. But just like anything else, to continue it on, to sustain it, we have to have that funding. And we can be thankful that not only our local politicians, but we've got a good relationship with those at the state as well, have helped to continue some of that funding so that our members can get out there. When it comes to statistics, some of the things that we've noticed, just looking back at 2018, Cincinnati is kind of a weird dynamic. I mean, it's so close to the Kentucky border as well as the Indiana border. So a lot of our overdoses are not really the residents always of Cincinnati. So that's one of the difficulties that our quick response teams notice. So I think there's probably been about 775 individuals over through 2018 that were contacted that were actually Cincinnati residents. Right. And of those, I think 38% actually, the ones that they actually made contact with, went into treatment. So we wish it was 100%, but the 38% for us has been a win, if you will. Now, one of the difficulties the fire department has, though, is once they get into treatment, we really don't necessarily know what happened to them until maybe you might see them, again on the streets later on. But I think the members that are part of the teams, they're passionate about it. They've been doing it, ever since its inception, and we hope to continue to stand up that program.
That's amazing. Lieutenant John Williams graduated from our course, all right, along with Chief Smith and others. And it's been amazing. And Dean Neil MacKinnon, I asked him if he would do a ride-along with us.
We did.
So he spent the first part of the day riding along with Lieutenant Williams. It was great. And then we put him the rest of the day in the back of a police cruiser. And one of his comments afterwards, there's no handle back there. So I'd like to open up for any questions with the chief, all right? This is an amazing program. A rare opportunity. How do you go about selecting those who would be making these home visits? Because it takes a unique approach.
And so we don't make it mandatory. We do
Yep.
select the volunteers. And so all of the ALS supervisors that participate in the program, no doubt are passionate about it. Larry mentioned John Williams. He grew up in the lower Price Hill area. So he's kind of had, from the inception, he had a passion for trying to help, really where he grew up at. And so, I mean, he's out there at every opportunity to kind of help people that he knew, ones that were friends of his family and so forth. So we find that definitely helps us as well, because it's, it can get tiresome just knocking on doors, particularly when you can't find individuals. And so I think people like that are a part of our QRTs definitely help us as well.
Yeah, and so we're clear, on the team is an EMS supervisor, a police officer, all right, and a substance abuse counselor. And so the three show up. And we were on Monday at Coleraine Township, and the counselor who's on their QRT team lives in Coleraine Township. I said, well, how many of your neighbors have you met since you've been on? Well, about 400. I said, you go to Kroger's? Yes, I see him. You go to church? Yes, I see him. And that's just a whole other aspect of a personal relationship. And that really breaks down the barriers.
Yeah.
So thank you very much for your leadership. Go for it.
Yeah, I'm part of the MAT group. I wanted to know, usually people call and somebody OD, they would leave. So is there, would they get arrested now if they call for a person that already OD?
No, in many cases, the police are so busy.
Right.
Let's be honest, they're so spread so thin that usually it's just the fire department that responds. I think it's, I don't know, Chief Smith, it might be less than 25% of calls that the police actually make. So, the vast majority is just fire only. And so, unless there are children involved,
right,
or there's danger with the vehicle, normally, the police don't even enter. We don't call for them. We just kind of treat it as we would any other medical emergency.
Oh, that's good. That's
And I
good.
think there's actually some identity for the individual that calls, as far as the police are concerned.
Indeed.
and the prosecutor.
And from a lawyer's perspective with HIPAA,
Right.
police records of Narcan saves is a
Right.
public record.
Okay.
So we don't have to rely on HIPAA-protected EMS run reports.
Right.
All right?
Okay.
Yeah, and then you all keep records of your visits, but you're not reporting those to the state because that's not an EMS run, in effect. Is that correct?
We just keep the stats
Right.
as far as the amount of runs, but
Right.
like you said, anything that's data-wise, other than that, no, it's not important.
Okay, thank you.
Amazing program. How about a round of applause? It takes true leadership. All right, I need some leadership here, all right? Yesterday, we're at the City of Monroe Fire Department, up I-75, and we're going through, presentations, and then I watched your video. I asked for permission if I could share that, all right? So you know more about board computing. You like to pull it up? Come on. All right, this is multitasking here, all right? I want to start it up with this video. And Chief John Sanders, can you kind of set up for us how this video came to be made?
Okay, so we'll talk a little bit more about some of the partnerships that we developed over the course of the last 4 years with the Community Paramedicine Program. We started that in a trial right at the end of 2015 when the scope of practice changed for EMTs and paramedics in Ohio. As you're aware, the governor signed a bill that allowed EMTs and paramedics to function in non-emergency roles. Originally, our scope of practice in Ohio was based on providing care with the intent to transport people, so it didn't really allow us to do things that were interactive with patients that might prevent or reduce the likelihood of a transport. So as we moved forward with that program and developed partnerships, we ended up with several interns from Miami University that were coming down and riding with our community paramedic as part of their different degree programs. There were many different ones that came down. We talked about a video last year and happened to have one of our interns in with us, and he said, wow, that's really weird. My dad owns a production company in Cleveland. So I've got all the equipment and everything to do a video. And we said, well, that would be awesome, but we don't have a lot of money laying around, so how could we work that out? And he said, you know what, I'll go get his stuff on the weekend, bring it down here, I'll do it for free. So we thought, well, this will be interesting to see how it actually turns out, because it's a young college kid that's going to have all this expensive equipment. But it actually turned out much better than we thought it would. And we wanted something that we could put out in the community that, in a very brief way, explained our program and what we did. And I think, other than the educational part that we'll talk about today, I think probably what we want to be able to do is spark an interest in change and tackling things that are new for you, because all these ideas, all these things that come up were developed by someone that had a passion to do something different than they were doing right now. And anyone will tell you that's been in the fire service, including myself, there's two things that we do not like in the fire service, and that's change and the way things are. So trying to get over those hurdles, to develop new things, and to pick out a priority in your jurisdiction, in your neighborhood, in your home that is important to you is important to everyone. So reach for the stars with those things, and good things will end up happening.
All right, they're going to connect us up. In the meantime, come on up to the podium, all right? We had the pleasure of flying up to Minneapolis together and doing ride-alongs with community paramedics who were hospital-based. And when they're hospital-based, then their report writing, we're sitting in the kitchen of an 80-plus-year-old woman, diabetes, some alcohol issues, some senility issues, and some other medical issues. 5 treating physicians. Vitals are taken. At first, there's the hug, because once a week, a visit with the community paramedic and this lovely lady. And when he's done, I said, when are you going to write the run report? Oh, I just sent that to her 5 treating physicians. What? Yeah, we're part of the hospital. We're on Epic. No problem. Unbelievable. Imagine having that service in your life. So that was eye-opening for me.
It was.
And then shortly after, you're holding a press conference.
Yes.
What's that about?
Yeah. So that trip really kind of brought everything into focus for us. And I think each agency, whether you're fire or doing something private or whatever, I mean, you're looking at focal points and trying to address things that are problematic. And one of the things that were problematic for us was our geriatric community. And we started looking at these things in 2015, and we started pulling all kinds of data, because that's what we do, is crunch numbers all the time. And we determined that a large population in our community had needs that weren't being met. And everybody has those, whether that's infant mortality or drug overdoses or whatever your individual area happens to have. And we decided that's the thing we were going to tackle in our community. So the community paramedic stuff was just kind of coming to fruition and starting to brew up in the state of Ohio. We started a trial program, but we didn't know a lot about taking care of old people that had not medical-related old people problems. So we had to sit down and interview about 90 old people. And I say old people with love, because we're all getting older. So I hit my 29th year last month, and I thought, where did the time go? So we started interviewing old people. And we said, okay, in the healthcare system, in what you do day to day in your life as a retiree living at home, some widowed, some not, what things trouble you or are problematic for you? And probably the largest percentage of the people that we interviewed said, it is the discharge process out of the hospital that's the hardest thing for me. So if you can imagine being 70, 80, 90 years old, being in the hospital for 8, 10, 12, 14 days, you're not eating, you're not sleeping, you're on new medications, and you probably, in all likelihood, just had some sort of procedure done. And then one morning the nurse comes in, sits on the edge of the bed and says, well, we're going to discharge you today. And they've got a big giant stack of papers, and they're going through page by page, and they're going, okay, now these are your new medications, and you have a follow-up appointment this date, and you have a specialist appointment this date. We don't want you to lift anything. You're not allowed to sit, not allowed to stand, not allowed to do stairs, all these things. And all you're thinking is, I just want to go home. I'm tired, I just want to go home. So they do. And they got their big stack of papers, and it ends up, Lord knows where, in their house. They still have that cabinet, and we've all seen that cabinet if you've been in the fire service, that has 800 different medications in it, right? Because they're old and they keep everything. So now they've got a page that has all their old medications on it. They got a page that has all their new medications on it. There's changes in dosages, all these other things, and it gets missed. So what happens inevitably? 3, 4, 5 days later, they lift something, they stand too long, they go upstairs, they bend over, they squat, they take the wrong medication or they miss their follow-up appointment, and they call 911. So we come out, we take them to the hospital, so now they're back in the hospital system again. If you're in the hospital system, you know that those return dates in under 30 days, they don't get paid for. So we're trying to figure out a way, how can we change that? Is there a way that we can intervene in that to help these people out? So after having met with all these old people and find out what went on with them, we developed a partnership with Atrium Medical Center, which is a premier system. And we laid our whole program out and said, hey, this is what we're trying to do in our community. We need a way to track all this information. So we ended up meeting and getting hooked up with J&B Medical. J&B Medical has a cloud-based computer product that has all kinds of toys. So it's a computer, everything's Bluetooth. So it's got a Bluetooth stethoscope, blood pressure cuff, blood sugar, end-tidal CO2, 12-lead EKG, all this stuff that's Bluetooth on it. So you literally go to the house, you open up your computer, you log on, you hook up all these devices all over this patient, you hit start, and it starts uploading all this information into their cloud-based program. So the program itself builds trends in these vital signs and all the stuff that you're putting in it. The physician, the PCP, the specialist, whoever has access to this program, they get a login. So we have our patient at home, and maybe they're a CHF patient and they have some other anomalies that they're dealing with. The physician can log onto the program and they can look at trends in this patient's weight, O2 saturation, blood pressure, heart rate, all these other things, and make a determination on this is a patient that's stable to be at home, or this is a patient that probably needs to come back in. It also has a camera on it, so we can zoom in like, I don't know, it's 200 or 300 times. It's an amazing camera. So they can actually do FaceTime type interaction with the patient in the home with our community paramedic as well. So you may have the physician log on from their office, our CP logs on in the home with the patient, and they actually do the FaceTime thing with the physician and say, okay, I'm in Mrs. Smith's house right now. You know, she's a CHF patient, her weight's up like 8 pounds, and we know if we deal with CHF patients, if their weight's up 8 pounds, they're retaining a lot of fluid. So maybe rather than have an 80-year-old patient that doesn't get around real well, that doesn't walk real well, out in the weather when it's 10 degrees and icy and snowy, and we run the risk of them falling, getting in and out of the car, because that happens all the time, or we're putting them into a physician's office or a hospital where they're maybe likely to catch something else that someone else has in the hospital, right? So there are risks involved in getting these people in the hospital or in the doctor's office if they don't need to be there. So what we can do with these types of programs is reduce the likelihood that they end up in the doctor's office at all, or that they end up in the ER unnecessarily because there's just no follow-up. This was important for me, more specifically. My mom passed from cancer, and she had a long battle with cancer. And at the end of her life, we had home health nurses coming in and all this other stuff, and she had to have her chest wall drained of fluid a couple times a day. And we talked about if we didn't have somebody to take care of her, if we didn't have somebody to come visit her that had a medical background, you know, what would we have done? I mean, there was just, you know, she would have been in a bad way. So that really, I think for me personally, triggered where we went with our program, because I said, hey, we got a lot of old people. We got to make sure these people have somebody that can follow up, visit, make sure they're doing okay. And it's also the emotional, psychological part of it too, because a lot of these folks have no one in their lives. There's no one that visits them, no one that checks on them. Maybe their family pops in, maybe they live on the other side of the country, but they have no one to come visit them. So that emotional part of having another human that's interested in how they're doing became a real prevalent thing. And it was probably more important in a lot of cases than the medical part was. They're getting dressed up, they're putting on makeup, they're doing their hair, they're making cookies. I mean, it's a big deal. That visit means something that you can't really, it's hard to put your hands on it.
From an administrative point of view, tell us the impact on you as a fire chief, because you got to pay somebody. Presumably you've taken somebody off the street. They're now a 40-hour plus person. And you're dealing with elected officials and explaining, so give us some sense of what the impact has been on you as a fire chief.
Yeah, so this was new in the state of Ohio. So it was hard to really bring in a lot of data and other historical information from Ohio. So from an ideology standpoint, we sat down with a lot of different folks, not the least of which was the city manager, our council, our medical director, and our staff, because this is, again, very different. As Chief Winston said earlier, I mean, they have voluntary people that do this. You don't want to force somebody to do this job, because you've got to be passionate about being in the field and treating people that need a different level of care than we do in emergencies. It's very, very different. So we want to have people that fit that role really, really well. We were fortunate in that going to Minnesota, seeing the program, and being able to bring back that information and saying, hey, these folks in their program made a commitment to people that needed help. There was a gap in that system, and somebody there at some point said, we're not going to let that continue. We're going to do something different. We're going to step up. We're going to develop programs that help these people out. To what end that is, well, we talked about up there. I mean, when you're doing community paramedic visits on people that live in a refrigerator box under a bridge, I would say that's reaching out pretty far. And that's the kind of program they run there. And we wanted to be able to do those kind of things. We don't have a lot of people living under bridges in my area, but everybody's got their demographic issues that they deal with. So the partnership building stuff was rough at first, again, because there's no real data to pull from. It was an idea. We started doing our home visits. We got some success with that, and we started bringing old people in to say, hey, tell us how this affected your life. Tell us how this affected you medically, having this service available to you. And it wasn't more than 2 or 3 of those going on that people were finally saying, okay, yeah, there's actually some good that can come out of this. We need to fund it. So we did a SAFER grant, which, if you're not familiar with the grants, it's a federal grant that provides money for personnel for the fire service. We were the first in the state of Ohio that actually got funding. This is kind of tricky the way I want to word this, but we got funding for our community paramedic position for a 2-year period. We didn't get funding specifically for the community paramedic. We got funding for an operational position to be able to move somebody out into that role. So we got that for 2 years. That ended last year. And our city council said, you know what, there's enough data, there's enough stories, there's enough everything else going on, we're going to keep it. This is a program we think we need to keep, and we need to keep it up and running. And then the partnerships started kicking in, and we had different people between the hospital and Miami University coming in saying, hey, we want to be a part of this. We said, well, what do you bring to the table? And they said, well, we can do all your data collection. We can write your white paper. We'll review all of your information for you. And the hospital was stepping up saying, we're going to get our discharge people involved. And when we discharge a patient back to your community, we're going to call your community paramedic so he knows. And if it's a day he's working, he's going to come to the hospital, and he's going to sit on the edge of the bed with a nurse while they're going through the discharge paperwork to make sure he knows exactly what's being said. And then he's going to have the paperwork signed with the patient at that point. He's going to say, hey, tomorrow I'm going to come to your house at 11 o'clock. We're going to go over your paperwork again if you've had a good night's sleep, and we're going to make sure you have everything at the house you need. Because when you discharge people from the hospital, you don't know what's at their house. You've never been to their house. You have no idea. So that's kind of how
I was
that.
amazed yesterday when your community paramedic shared that virtually all the patients he visits now has his cell phone.
Yes.
So it's a Saturday afternoon, he's home with his wife and kids, and the call comes.
Yeah, I don't encourage that.
No, it's reality, isn't it?
It is, and that is a great example of the commitment you get when you start dealing with these people, the relationship that you build, that level of trust when they're calling him before they're calling their family, and their family lives close. Yes, ma'am, go ahead.
Yes, I'm from an MAT group, I want to ask you, what about the older person that's been cut off their medication, the opioid epidemic is large, but they've been cut off their medication, they've been on years, and they don't really know their detoxing. You know, how do you reach those patients? Because they're going out on the streets. And I've seen a lot of elder people going on the street because they can't get their medication.
Right.
You know, these doctors are scared to medicate them, and they are.
Right.
You know, so how do you reach those patients?
Well, we have to get a referral to get in to see people first. So that referral has to either come from family, it comes from the EMS crews that do the transports, or it comes from the hospital based on what they see on a particular patient in a hospital. Now this is the other piece of this, it's really simple. There are a number of services that are available to the elderly in each community. A lot of different things, Meals on Wheels and discounts on medications, delivery medications, all the other stuff. But I mean, if you're old, living in a house house, you're still using a phone book to find stuff.
Right.
And you're not gonna find it. And they don't have a computer or anything, they can do a Google search or anything like that.
Right.
So what we're doing is we're intervening on those calls, we're sitting down with patients, and we're saying, okay, again, what problems are you dealing with right now? And if it happens to be, I can't get my medications, or they're too expensive, then we link them up with services that provide help in those areas, in that region. So not only saying, hey, we're gonna bring somebody in from Council on Aging that's gonna sit down with you and me, and we're gonna talk about this stuff, because trust is a big issue with our elderly community. And we saw that played out with some of the services in our area that we met with, and they said, hey, we don't get any calls. We have all this funding and all this stuff that we can provide for our elderly community, and nobody will take advantage of it. We said, well, how are you dealing with these people? They said, well, we'll call them, and we'll say, hey, this is so-and-so from blah, blah agency, and we're providing this and this and this. What kind of insurance do you have? What's your social security number? I'm like, oh. Yeah, they're not gonna give you that.
Right.
That's not gonna happen. But who they will give it to is us, because they trust us. They'll let us in their house. So we partnered up with those folks and said, hey, look, if we have somebody that needs services from Butler County Elderly Services or Council on Aging or one of these other agencies, we set that meeting up and we meet them at the house with the patient at the same time. Because then we can tell the patient, these people are with us. They're good. You can give them the information you need to give them. And that kind of builds, again, that bridge between the agencies that have difficulty getting in the homes of people that have trust issues. I mean, let's face it, people are getting robbed routinely in one form or another. So getting us in the homes helps.
All right, press that button, we want to see that video.
Do you?
Come on. Bring it
I
in.
actually got an award for this. It was
Yeah.
interesting. It had the host with the head much like a rock. Community Paramedicine was approved for operation in the state of Ohio by Governor John Kasich on June 30th, 2015, and went into effect on October 1st, 2015. A change in the scope of practice for Ohio EMTs and paramedics allows non-emergency evaluation without the intent to transport. Community paramedicine or mobile integrated healthcare will allow each community to perform a risk analysis to determine what and if an underserved population exists. Following this determination, a plan can be established to address the issue through community paramedicine.
Hi, I'm Aaron Vance. I'm the community paramedic for the City of Monroe Fire Department. Our goal is to create a short-term interventional program that prevents unnecessary ER visits and hospital readmissions. We do this by clarifying discharge instructions, medication regimens, home safety inspections, and referrals to senior services.
The City of Monroe Fire Department was one of the first trial programs to operate in the state of Ohio. The program was designed to address the needs of the community-dwelling senior population through 5 specific areas: post-AMI, post-CVA, exacerbated respiratory history, long bone and hip fractures, and at-risk diabetics. One of the more critical needs discovered through the risk assessment was the ability for hospital discharge patients to function within the parameters of the discharge instructions. Failure to comprehend this critical piece of data can and has resulted in readmission of our patients.
Community paramedicine provides an additional level of service for our independent residents that they normally wouldn't have.
Along with community paramedicine, we have the EMS signpost, which is an electronic version of the Vial of Life. So those residents that signed up for EMS signpost, we had the information readily available for them.
The City of Monroe is committed to this new level of service and is working to expand the program utilizing modern computer and software products. Our priority is to allow our community-dwelling seniors to prosper following critical medical events and to reduce the likelihood of hospital admission through case-specific care plans.
I called the fire department to update them with some personal information about our home. Wanted to make sure that they were able to get in if ever the occasion was to arise when my mother needed help and no one was here at the house with her. So Chief Centers called me back when I left him a message and was telling me about this new program that Aaron Vance was spearheading about this community program where they would gather all of my mother's or anyone's information, their medical history, their medication, past surgeries or accidents, letting them know, everything about them. They've put this on a magnetic strip so that they can get this information easily.
Well, he checks to see if my blood pressure and everything is okay, asks me about my medication, if I'm taking it right, and if I'm taking all of it, because I take 13 pills a day. And so we talk about that and how I'm handling my life, for one thing, being a widow. And I don't know, it just feels so good to know somebody out there is taking care of you and watching out for you. I really appreciate the fire department and Aaron.
One of the greatest advantages of mobile integrated healthcare is the ability to custom build a system that meets the needs of your community. In 2015, we initiated a risk assessment to determine where we may have gaps in our system and service delivery. We were able to get the program up and running based on data and feedback, interviews with our community, to determine what direction we wanted to go with the program, and ultimately what services we would provide through that program. Thus far, this has been one of the best programs that we've implemented from the aspect of community needs. It's been very popular. We have the trust of the community to be able to get into their homes, to explain how the program works, and to provide services that were previously unmet for most of the folks that we deal with. These can be things as simple as Meals on Wheels, transportation services, and assistance with pharmaceutical needs. But generally speaking, the program has been outstanding, the feedback very positive, and it's our intent to build on that program and to widen the aspect of services we're providing through it.
A quick question for
Yes,
you.
sir.
So I'm from Clear Creek Township. We have a pretty similar demographic, and one of the things that we've noticed in our community is they're building a lot of assisted living facilities and memory care units. And a lot of the problems that you described about patients not taking their medications or them falling down in the middle of the night, a lot of those things happen inside of those assisted living facilities and memory care units, and that is a significant increase in our EMS response. Have you guys crossed that boundary yet of exploring into those facilities?
Yeah, we have. Our community paramedic is in a partnership with a fall prevention program with Atrium, which you're probably familiar. They've been doing a lot of that work. So Mount Pleasant, our bigger nursing home, it's kind of complex in that it's a village. So it's got single-family homes and duplexes, condos, apartment buildings, and then an actual large extended care facility in it. So a lot of the patients we visit, while they are under the supervision of Mount Pleasant, are in private residences. So we still go see a lot of those folks, even in that community, to do fall prevention stuff. We do, to the extent we can, the ones that are in the facilities to be able to do training to help those folks out. What has helped the most is that in doing the referral work where we can get in the houses, we're actually able now to do fall prevention and fire scope stuff in their residences. So where we used to pick up people and go back to the station, then they fall, we pick them up again, we go back to the station, they fall, pick them again, go back to the station. We started actually spending some time saying, okay, we need to figure out why they're falling. Because we're not going to reduce our call volume with these people if we don't figure out why they're falling in the first place. That's got to be addressed at some point. And then we started looking at these falls they were having, these hip fractures. Well, a hip fracture is not really, for us as a fire service, a real high strain call. I mean, it happens like all the time, right? So we started looking at the data on these hip fracture calls, and we said, holy crap. A person that has a hip fracture is, in all likelihood, going to have another fall within 1 year. That's already been proven. And the ones that have a fall after their 1 year are going to die, a percentage of them, 72%, 73%, are going to be dead within 2 years, all related to that fall. So that refreshed our scope on that and why we were looking at it. And we realized at that point, we're like, this has got to be addressed. This is like a bad thing. This is actually killing people. So then we started getting into the houses and look at things more closely. Do they have trip hazards? Do they have carpets? Do they have cords? Do they have oxygen tubing running all over the house? All these other things. And we try to intervene that way with folks, do education with them, give them data on fall prevention, and actually sit down with them and explain. This is not one of those stupid other things that you get paid for. You need to listen to this and read it, because this is what's going to happen if you have a fall. if you have a hip fracture, you're going to fall again this percentage of the time in a year. And then this is going to happen, and you're going to get hospitalized, and it all goes downhill from there.
Wow, absolutely amazing. How about a round of applause? That is amazing.
I can't.
What are you saying here? What's his closing comment?
You know, honestly, I don't remember. I think I was saying something like, we're going to expand our program as we move through it and find more information. It's really, I don't know, in a way to motivate you. There's something out there for you to do that's more than you're doing right now.
Unbelievable.
Just grab it.
Makeup artist and all that kind of stuff? Or?
Yeah, no. Well, I mean, did it look like I had a makeup artist? It didn't.
All right, JD, come on up, all right, my friend, because we're talking about the community paramedics. JD Postage, Violet Township. If you ever want to do a ride-along that will amaze you, that was a shift that I'll never forget. I've been in the fire service 30 plus years, and in one shift, well, let me just set up a picture. There's a young lady, I'd say in her early 20s. She's setting out her pills for the week. Pill after pill after pill after pill. And it's a hug. And you know, and the conduit, all that well kept. And then as we're leaving, I said, whose car is that in the driveway? Because this is a mental issue. Oh, that's hers. When we're done, she's driving to work. Sober. And you continue to see that.
Mm-hmm. Yep.
Give us a big picture. What's your day like?
Typically, my day starts that there's, at most places, I don't know, at some of these other places, my day is really depending on my patients. So I can start from anywhere at 7:30 in the morning to 9 o'clock in the morning until 5 or 6 o'clock at night. It just really depends. It's all driven by the patient. My chief has kind of given me the latitude to set my own schedule. I have overtime, and he's okay with that as long as I'm doing what I'm supposed to be doing and taking care of our patients. Our program started with a partnership with Mount Carmel Health Systems. We started out with CHF patients, and then it just kind of blossomed from there, where now I get referrals from everywhere. So we started out with Mount Carmel, but I was also getting referrals from the guys for frequent utilizers. So somebody that had fallen a lot, people they were just running on the house over and over and over. And a lot of it could be contributed to discharge, not understanding the discharge instructions, not understanding how to get their meds, couldn't get their meds. So what we did was is then we said, okay, you know, the door's kind of open, these guys that refer you, people go out and see them. Well, then after we had some success stories, then, you know, I was in an apartment complex manager's office talking about rent assistance and all that, and then it just kind of blossomed there. Now that we get referrals from apartment complex managers, we get referrals from churches. I work very well with some of the physician groups in our areas where they actually refer patients to me as well. I'm part of the Fairfield County Overdose Response Team, which is Project Fort. And we have a very similar model. Myself will go out. We have a peer advocate that goes out, and then we have a detective from the major crime unit. And we all go out and meet with the patient. And what we try to do is figure out, are they ready for treatment? And if they are, we try to link them with services in the community. And we also have case managers, if we need to, that we can call. So if they're ready, we can call one of the case managers and they can start that assessment process either that day or the next day. But we try to get them in within 1 to 2 days to get them start getting them assessed. If they need detoxed, there's a local detox center that we have in Violet Township. We can load them up and we'll take them down there to get detoxed. It just really, really depends. So like I said, I average about 4 or 5 visits a day. Some days I can go up to about 8 visits. It really, really depends. My week is anywhere from like 20 to 25 visits. It really, really depends. Now that we're
You all have your cell phone?
Yes. Actually, they have an office number that goes to my cell phone, which makes it a lot easier. So as we're ramping up more programs with Mount Carmel, we're slowly starting to get busier. We have the CHF program. We have now a stroke follow-up program where we go in and we follow up the patient to make sure obviously they have their meds. but we also do an IH screening on them to make sure that they are progressing, and if they're not progressing, what do we need to do? Do we need to get them physical therapy? Do they need a little bit more home health? The one thing that we had talked about yesterday was a great point, was home health. Initially, we
Are
did
you
have
the
some
enemy of nurses and home
Yeah.
health care?
Initially, there was some like, oh my God, we got paramedics now coming in the home, doing home visits. What's going on? You're treading into our territory. But actually, we're bridging the gap. There's a lot of silos that exist in healthcare, and all these guys know right now. So we're just bridging that gap. So one of the things that we found is, in some of these cases, one, home health couldn't get in there for 24, 48, 72 hours. So we're kind of bridging that gap to allow them to get in there, because if they go back to the hospital, they're not going to get paid for the service. The other two is they're only going to be in there for a certain amount of time. So we're going to be able to follow that patient after they leave. And a lot of times, the home health agencies will call me to work with them as they're in there as well, because the more eyes are on the patient, the more contact time we have with the patient, they're more likely to follow through with their care plan. So it's about us working together to make sure that patient stays in their home, because that's where that patient wants to be. Nobody wants to be in the hospital. It's not the Hilton, it's not the Ritz-Carlton. So nobody wants to be in the hospital. So we're working together now. So the director of Mount Carmel Home Health rode with me one day, and he was actually amazed at some of the things that I did. And there was a little bit of a crossover, but there was a lot of different that I did as well. So he was like, yeah, you're not like treading on our territory. You're not competing with us. You're actually trying to help us out. And it was nice because one of our visits, we were out with one of his nurses.
Wow.
So, and just seeing how well we work together, that really opened his eyes as well.
Well, and early on, the Ohio EMS Board was frankly concerned. We're holding these seminars here, and they want to make sure people were not exceeding their scope of practice. So tell us about how you and your medical director interact.
So our protocol is pretty advanced. I mean, right now we will diaries for somebody in their home, we do labs in their home, and when I do that, I call my medical director. Anytime I give meds, I call my medical director. So one of the new programs that we started, and it's actually starting with OSU East, is like, if the patient doesn't have certain prescriptions, we'll have them in our bag and we'll hand it to them, so that way they have their blood pressure medicines or their Plavix until they can get it. And when we do that, we got to make sure our medical director knows, and he knows what we're doing. Another thing we're looking at is with high blood pressure. Can we treat their high blood pressure at home until they get to their family doctor? So that's another thing, and that's where we involve Dr. Zeeb and a pharmacist, just to make sure that we're not going to drop their blood pressure to a really low level.
And there are a few pharmacists in the room, including a dean of pharmacy. Would you share the Tylenol story? You really got my attention yesterday.
So another pharmacy that I work very well with is Mount Carmel Retail Pharmacy, because they have programs that they can put people into, just like what you're talking about, where they can't get their meds. They can absorb the cost of their meds. So I have a guy that has that same problem, so that's why we put him up at Mount Carmel Retail Pharmacy. So his ortho doc, he wanted Tylenol. So somehow his ortho doc called in a prescription for Tramadol. So this guy also takes other medicine for his anxiety. So on top of all his anxiety meds, he takes his Tramadol, and then he gets in the car and drives. So you see how this is going to work out, huh? He's swerving all over the road like he's drunk. Cops pull him over. They call us. The guys know that I see this patient, calls me and say, hey, Harry's drunk. I go, Harry doesn't drink alcohol. Something's going on. Harry doesn't do that. And so what ends up happening is they take him to the hospital. I have a key to his apartment. So I went to his apartment and I was like, okay, something's not right here. Something's going on. So I look there and I see this bottle of Tramadol. I'm like, what is this? What is this? So I'm like, this is supposed to be Tylenol. So I called the pharmacist. She's like, yeah, we delivered that yesterday. I'm like, no, this is supposed to be Tylenol. He took this with him. And she's like, oh. So she gets on the phone and calls the ER doc, because the ER doc's going to admit this, because they don't know what's going on. He doesn't drink and all that, so they have no clue what's going on with him. So we fill in the pieces together and let the doc know, oh, this is what he took. And then the doc's like, oh, okay, that makes more sense now. That's why he's acting the way he is. So we'll keep him here for a couple more hours, and then we'll discharge him and let the Tramadol wear off. So now we have it set up that my patients that go to the pharmacy, they'll call me when any kind of new prescriptions is sent to their address, so that we don't have this screw up. Because it was just a screw up. I don't know how it happened, but it did. It did.
Unreal. So What's your prediction? Now that you've got this partnership, notice the headline here, partnership. Now that you have this partnership with Mount Carmel Hospital, what's your vision? What's happening in the near future?
We're looking at a bunch of different service lines, different programs. We're looking at partnership with Meals on Wheels, with the hospital system, that where we'll have a remote monitoring center. The patients will have a blood pressure cuff, pulse ox, a scale, a glucometer. They'll take their own vitals every morning. It'll come to a dashboard on my computer, and then we'll trend that, and then we'll also set parameters. So if it's outside that parameter, then what will happen is it'll prompt me to make a phone call to see how they're doing. And if we need to, then we prompt to do a visit. We're also looking at mental health partnership where we've already done this with another hospital, Columbus Springs, but where we directly admit people right into the mental health facility. We bypass the ER, we do a medical clearance, and we get them right into the facility.
Wow.
So we're going to do that as a pilot with Mount Carmel as well.
Amazing. From a fire chief administrative issue, same question I asked John. What's this done to his life?
Well, chime in at any time because you're the fire chief. No, you're doing great. You're doing great. So here's the thing. Anytime those big trucks go out on the road, there's always an inherent risk, right? And how many calls that we go on, most of them probably don't need to go to the hospital. They just need that warm and fuzzy feeling that somebody's out there, or they need some sort of direction on where to go. And now we have that opportunity. Before that, the fire department is a jack of all and master of none, because we do a whole lot of great things, but we're never the master of anything. So what this now does is it gives the guys that are out there on the streets an option. So before they're like, I don't know, and now, and their alternative was taking them to the ER. Well, now they have an alternative that, hey, JD will come see you and we'll try to figure things out. And do we need to get you into a doctor? Do you need some home health? I've gotten into homes and I've actually referred them into home health because that's what they need. It's not about the competition, it's about the collaboration.
From an elected official's perspective, what's the impact on, this is a township, so you've got 3 township trustees.
Yeah, we have 3. From what I gather, they seem to love it. They hear a lot of good stories. We've had actually one of my township trustees, I saw one of his in-laws and his best friend, and since then, he's like all about it.
Wow. And of course, you're supported by levies, so I guess this would help with levy votes.
Yep. Oh, yeah. Oh, yeah.
Excuse me. Do you take Narcan to the fire chief and the police officers? Do they take that? Or are they able to?
To hand it out?
No. Something like that.
Yes, we use Narcan.
Okay, police officers too?
Yep.
Oh, that's great.
Yep.
That's great.
It's amazing.
I just want to chime in one thing on that real quick, because this is one of the things we had issues with some of our elected officials, not even specifically in mine, but in other places where we went out and met with other people. And it's always about the risk and the liability of doing this because it's different and it's new. And what we've told most of those folks is, our folks are on the street every day, stopping people's hearts, putting them to sleep, cutting a hole in their throat and shoving a tube in there, giving these medications every single day that can either work really great or essentially kill them if we don't have all the information we need. We're driving $500,000 trucks and $250,000 ambulances with $50,000 cardiac monitors in them. This community paramedicine stuff we're doing is not even a fraction of the risk we take doing the stuff we do every day. Because what we've done every day, everybody's numb to that, because that's the way we've always done it. We've always done these things. We've always driven trucks around, red light siren, through traffic. There are way more risks in doing the stuff we do on the 911 side than there is doing the proactive stuff we do on the community paramedicine, the home visit side. Mm-hmm. And you keep that in mind when you have to deal with your elected officials.
And yesterday we had Jamie Wilson, paramedic, nurse, now hospital rep. What a great background for you to be interacting with. And we had quite a discussion about the federal government's new pilot and what the implications are for the fire service. What's your sense of, because this is a pilot program whereby it's an inducement to not take patients to an ER.
I think the government, one, is saving money. They're looking at saving money. And two, it's about
the health of the patient. The ER is not always the best place for this patient, you know, and who knows the patient's best is their primary care physician. So that's where they really should be. That's who they should be sitting in front of. So how do we get them there, and how do we, you know, get that appointment set up, and how do we, you know, make sure that they follow through with what their primary care wants them to do?
If I could ask a question related to that cost savings, right? So you had one position that you funded through SAFER for the 2 years, and then you decided to keep the position. How do you quantify or identify your savings statistically to justify the additional position?
That's a great question. On our end, I can tell you that we saw a reduction in service calls of probably in the single digits in the areas where we had higher call volumes, and we saw a reduction in the number of patients that we had repeat visits. So the ones that we were transporting, some of them 30, 40, 50 times a year, we were able to get them either into programs or deal with the family direct or get them in nursing homes. So the reality of it is we're not going to make money doing this. It's just, it's never going to happen. We hope to be able to offset our cost with a stipend such as they have in Minneapolis at some point, but it's never going to fully fund the program. So it's a commitment level from council and the city managers to say that is something we want to be involved with. We think that's a good thing from a marketing standpoint to offer our community.
And then how do you decide where to put it, right? Because this is sort of a mix for us. I'm actually not the EMS chief. I'm responsible for risk reduction in our city. So it sounds like it's got like sort of a dual component.
So think of it this way. You got fire prevention. This is EMS prevention. You spend all this money to reduce, and we do a great job of fire prevention. Fires are down, deaths are down, right? We do a great job of that. But 85% of our runs we're not doing anything about, and that's the health of our community. So this is what it's about. It's about your health of your community. How can you make them healthier? So that's the approach. I'm sorry, Larry. That's the approach that our chief has looked at. Is I'm making my health my community healthier. I'm taking a proactive approach in their health.
And you're expecting next year to have yet another medic
Yes.
providing the same
Yes.
services. So that to me says it all. The department and that township's committed to that investment. Fantastic. Have a round of applause.
Actually, that was a perfect segue into my presentation.
So we're going to talk about Indiana for a minute, all right?
Hopefully this comes up.
Hopefully my PowerPoints will come up, all right?
That's why I love coming here every year, the opportunity and share and network. Let's see if I can get this going.
All right, look at that. And I bought a new clicker yesterday. Give it a ride, would you?
Yeah.
All right.
So when we're talking about infrastructure and creating long-term sustainability of this program, it's the economics. That's what drives everything. So we got to talk about data and analytics and how to build those community partnerships. So the big thing that we've done is be able to link this to an economic model. We've been responsible for creating every initiative in community paramedicine for the state of Indiana and making that a replicatable model for other communities. So a lot of what I do is stakeholder engagement. So I travel to communities all across the country, trying to set up those collaborative partnerships, because if you're going to stay siloed, it's never going to work. So it's about creating a healthier community. Healthier communities are higher earning communities. So how do we make that community more resilient and build health equity for our community? And it's through shared value. It's finding key economic partners, whether it's local business. A lot of what we're able to do is support our industry to make them healthier, making a more ready and able workforce. So demonstrating that kind of collaborative leadership is also enticing new business and industry to move into our community. Another thing we want to do is with all the communities paramedic programs, they're kind of plucking that low-hanging fruit, right? Everyone's targeting heart failure and looking at that because of the economics attached to it. We know an average readmission may be $15,000 or more. An ER visit's going to be $5,000 or more. An average admission is about $21,000. So what we've been able to do is collaborate with QSource. QSource is an independent quality assurance agency for CMS and get that claims data we can show the effectiveness of our program. So just like a lot of departments around here, we didn't need another program to keep our guys busy. We couldn't steal guys off the trucks to do this program, and selecting people for this program, again, you need the right people that are motivated for the right reasons. So we have cherry-picked the best of the best that wanted to do this. For our department, this is about longevity and creating a better work environment for our people. So that's what we're able to do. What we're doing, and when I talk about the low-hanging fruit, you got to start somewhere. Heart failure is the most recognized thing. It impacts the hospitals. But it's truly, if you're going to build a more resilient community and affect the health of everybody, you have to look at the social determinants. And it's hard to do one program and not look at everything when you're wrapping around services. So for our community, we did start with heart failure, which led to chronic disease, and we're very, very successful with reducing admissions out of the ER, 24-hour observations, and just inpatient admissions by over 80%, nearly 90% at some points. And we looked at utilization of services 1 year prior to enrollment in our program and then 1 year post-utilization, and we were able to keep those numbers still at 60% and reduce the overall cost of care out of the ER by over $400,000. That's without looking at transfer to extended care facilities, moving people to occupational therapy and stuff like that. It's all about patient-centered care and linking them to the right services. So right now, we're also providing care with pre- and postnatal follow-up visits. We enroll patients as early as 12 weeks and continue care 16 weeks postpartum. We deliver a lot of high-level clinical care in the home, MacKinnon injections and steroid injections to help low birth weights and preterm deliveries, and then monitoring hypertension as far as 16 weeks out as well. We know falls in the home. When you were talking about dependency issues with our seniors, that's a lot of what we're looking at. Our fire department, 1/4 of our call volume is attributed to falls or lift assist. So what we've done is we've partnered with No2. It's similar to a lot of health information exchanges to where we're able to do the med rec right in the home. So whether that patient's using McKesson, Cerner, or Epic, we're able to look at the medications. And through our medics training with brief action planning, we're able to make short-term health style changes to affect their overall quality of health.
I would think overdose would be the highest quality. I mean, would be at the top of, you know.
Well, overdoses do happen with our seniors.
Right.
Chronic pain management.
Right.
When they're unable through other social determinants, whether it's transportation or housing insecurities, medication insecurities, that really exacerbates other disease conditions, and it causes real problems for our seniors that sometimes when we transport them to the ER goes unrecognized. It's not recognized that they may be withdrawing, and that's what's causing their unknown pain and stuff like that. So,
Ohio EMS board has so far decided not to certify community paramedics. What's Indiana doing in that regard?
So I've been a part of the legislation and doing a lot of grassroots efforts. So I've had quite a few politicians in our community that have drafted legislation for us. 3 state senators, and it just continued to pick up more and more when I was able to go over and meet with them at the State House and speak with them. Our resolution passed 47-0 out of the Senate, and now it's in the House, which the authors of that have continued to grow, and the sponsors. So we're looking where our program will be a replicatable model and a financially sustainable model through Medicaid July 1st. So the numbers do back this up.
So will it be a state certification on your card?
No, you will be credentialed through your own medical director, and then the state medical director will approve it. Another thing that we're doing that we feel is really innovative to go along with our falls is our overdose response team. We had the opportunity early last year to start coming over here and learning from the Hamilton County Opioid Coalition and riding with Cincinnati Fire Department to really see what best practice is and how we can grow our own program. From that we were contacted by our health secretary to ask what we could do with opioid response on a higher level. We came up with an idea that we felt was pretty innovative, to where we will be delivering MAT treatment in the home following an ER visit. So the induction will take place in the ER, and then the handoff will go to us, and primary care will assist managing that care for up to 2 weeks in the home until they can get inpatient services with behavioral health, and they'll manage that long-term care.
For a week before you come into service.
Up to 2 weeks with mat therapy in the home.
Okay.
We're also reaching out to our jails. We want to be good partners with our jail system. Right now, they're only allowing us, upon release, to do the HIV and HVC testing, and then treatment, transportation to primary care, behavioral health. But what we really want to be included with is the MAT inductions in the jail. We want a COWS assessment right on intake, and that's where we feel that it would be most successful, reducing recidivism rates and getting them into long-term recovery.
Right.
So,
What's your prediction? What do you see in the future?
I see just that. I see within a year we'll begin seeing our patients in the home with Matt in May, and I'm hoping we have a fantastic relationship with our local and county police and our jail. We've had multiple meetings on this, and there's actually a fantastic program. I thought I was really innovative, and I came up with this model, and I just found out through an interview with EMS World that there's a better program in the Florida area that's already doing it, and they've been doing it for a year and a half.
Wow.
And it's fantastic with the numbers that they're showing.
Same question I've asked the other two presenters. What's the impact on the fire chief and his management responsibility?
It's been responsibility. So this isn't, we've been doing this since 2013, and I still don't have it wrote into my job title. So it's a lot of extra work, but it's really worth it because we're providing more services to our community and managing the expectations that should be delivered to every community. That expectation that somebody is going to be there to take care of your mom, your son, your daughter, your child, and helping with those services.
Wow. And from your elected officials' perspective, why is this in their interest?
Because it promotes our community, it promotes growth, economic development, and our seniors have the most amount of free spending money. So if we're making a community that really embraces that and helps them age in place, our community is going to grow and better from it.
Wow. Amazing.
It expands our workforce at the fire department. It puts more emphasis on doing this. Third-party payers do this. Private industry is a part of this. But really to get that buy-in from the community and to get people to listen to you and trust you, it comes best from the fire service. We're the best program to partner with because of our transparency. So if you want to see my numbers, all you got to do is call my clerk treasurer's office. The budget's right there. We're not doing this to make money. We're there to support our fire department and our community.
You can just give us an idea about your demographic, size of your city, size of your department.
We're small. We're nowhere near Cincinnati. So the community I serve is 38,000. In the city, we have about 16,000 people.
How many sworn personnel do you have on your
50.
board? 50.
We have 14 per shift. So I don't take guys off the truck. I have 4 people full-time, 2 in chronic disease management, 1 in prenatal and OB, and 1 in falls, mental health, and substance use disorder. And then we have just brought on a full-time social worker.
Wow. Amazing. Absolutely. How about
That's
a round of applause?
with the fire department.
All right. Now, Jim made the mistake of calling me and saying, hey, Larry, I know you're doing a seminar, and as you know, we're thinking about starting. So I really wanted to have a perspective of somebody who's thinking about starting and what the dynamics are. Maybe after you've heard all this, I don't know if you're still interested in starting, but your chief's in the room. So.
Well, thanks, Larry.
All right.
Thanks, Larry. So, to Larry's statement, I've been working on this for a number of years. Community paramedicine was something I read about 5 years ago, and it was just trying to get traction. So 3 years ago, I actually was in one of the first classes that Larry put on. I was after the week program. We went up and visited chief centers up in Monroe. We did all that. Following that, it sparked an interest trying to get the wheels turning, and as these gentlemen here have mentioned, there's silos when it comes to the hospital systems and all the different organizations. So the big barrier is just trying to break through those silos and find out who to talk to, who to connect with, who to network with. So from there, I went to Hennepin College and did a 14 credit hour program. So I'm going to kind of give you the journey. I call it the community paramedic journey for the fire guys that are sitting here going, how do we make this happen? They should let me go first, because these really are the mentors that I seek out. I went up and visited JD, spent a day with him. I've been talking with Chief Miller for the last year. So they're helping me progress, where we are at in Miami Township. So I'm with Miami Township Claremont, by the way.
And would your chief please rise for a minute?
So,
because you're going to be in his wallet before long.
I'm trying to get this. I'm trying to get in his wallet, actually, but he's totally on board. So at that point, I call it the journey, because it has been a journey. So I did the program with Larry. I went and did the Hennepin program, spent the 14 credit hour class, and then I had to do 188 hours of clinical time. Some of that time was spent with JD, some of it was spent in the hospitals, going and sitting through some of the different departments and finding out what do I need to do on the outside, what happens to patients when I bring them in and they end up in orthopedics, they end up in respiratory therapy, so on and so forth. So all that clinical time, I was still trying to figure out, how do I make a program like JD has? How do I make a program like Chief Miller had? How do I tie into what Chief Centers is doing up in Monroe? So I looked. So for the fire guys, what I did is I looked internally at what am I already doing? So you guys do homes, you do a community paramedic program. It's just not making any, bringing any money in to help offset what you do. So I looked at what we did. I had a home safety program that I was already doing. I've been doing it for 14 years. We get into our seniors' homes. Our crews would recognize that, hey, there's a need. And so they would send me an email, they would call me, and I would show up the next duty day, and I would go and spend an hour, however much time I could spend, and we'd do a home safety check. So we would go through a home with a checklist. We would look at their medicines. We would do medication compliance. We would try to connect them to services. So I've been doing that for a long time. On top of that, we've got the seniors that you can't get in their homes, so we have the Knox Box program. If you guys aren't doing the home Knox Box program through Knox Box, you should be. The boxes are $183. You can get them to pay for them if you get funding, but then you put the box on their home and we don't have to break their door in, bust a window, try to figure out how to get in their home. So we were doing that already. Fault prevention, I was Clear Creek, so you talk about fault prevention. And to Chief Miller's thing, it's a quarter of what we do. And we've got all the assisted livings, we've got all the retirement homes coming in, we've got all the memory cares coming in, and they're inundating. And so last year we had, I think, 800 falls out of 4,500 EMS runs. So to your point, fall prevention is something we do. So it's a story that I can share is a lady that she was the frequent lady, lived by herself, her husband had died, kids are gone, and she was falling about once or twice a week. What we found out was that she was drinking. So she would start drinking in the middle of the afternoon. Well, by late afternoon, she was falling down. And we were making it twice a week. And so finally, it kind of got onto my radar, and I went out and visited her. I spent an hour with her, and I realized what was happening. She was taking her Zoloft in the morning with all her other meds, and then she was having 2 or 3 afternoon screwdrivers. Well, that was a bad combination. So we sat and talked. We had a very candid conversation. I called her daughter. We looked at her meds. I called the pharmacy. I talked to the pharmacist, to what JD is kind of doing with his folks. And after we did that, she didn't have another EMS run for 3 months. Wow. So that's, to me, that's positive results. And I've got, I can tell you more of those things, but it's that interaction and it's that compassion and care that really makes a difference. And so to that point, I just looked, like I said, fall prevention. So Clear Creek, we go out and I do a lot of education in our big communities. At least twice a year, I do a fall prevention. We go out and educate. We do a health fair, and we actually do genetic tests. And so, whatever the residents are, I have Green Medical come out, and they actually look at every walker, every wheelchair, every, scooter, and they almost every one of them needs some kind of an adjustment. And they looked at 35 walkers and they made adjustments to 25 of them. Either fixed brakes, adjusted the right height, because a lot of people just buy those things and they don't know how to use them. No one actually set the height or anything else up for them. And none of them use the brakes, they use them for scooters to sit on. So, it's education. We did start a addiction response team or a quick response team with Claremont County Recovery Center. We did that in 17 and October of 17. So we've been doing that for about a year.
Yeah, we had those counselors address us on Monday.
Yeah, so Christy's one of our counselors. So similar model, very similar model. A police officer, myself, or one of the other 3 paramedics, we go out on Tuesdays and we take one of the recovery coaches with us. And we go out, and follow up on the overdoses. Really, it's not just overdose with heroin, it's all substances, because if they can't get heroin, they're going to go to meth. If they can't get the meth, they're going to do whatever. So all of those interactions, we look up and we go out on Tuesdays. And we've gotten a number, I don't know what the numbers are off the top of my head, but a very big success rate, right, Christy? So we're doing all these things, and in the process of that, over the last 2 years, I've been pushing those silos. So where are we at today? Chief Kelly and I have been progressively pushing both Tri-Health and Mercy, because that's where I take 2,500 people to Tri-Health every year and 600 people to Mercy Anderson every year. And it's like, so we are finally getting to the right people. And a lot of that was with Chief Miller came out and did a talk for us, and I invited all the players that I could possibly think of, and the light bulb went off for them. And so from there, the wheel really started to spin. So we actively are currently working on grants with both Tri-Health and with Mercy. They got some grant money put in to help fund the program, because I'm sure Chief Kelly will tell you, we're busy and we've got a lot of new guys. We got a lot of guys retiring. Our budget is not going to sustain taking me off shift and just spending another $100,000 of benefits to replace me. It's not going to happen. So the real issue is really the funding. And so that's what we're working on. And like I said, I count on these guys all the time. I make phone calls to them, to try to figure this out. But we do have relationships, and that's what it is. It's networking, it's relationships, it's a lot of time on my days off, because on shift there's not enough time in a 24-hour shift with all the other things I do. So we do a lot, on my days off. So,
any questions? Yes.
Actually, I have a question to the whole panel. My name is Sharitha Wooten, and I am an MSW grad student over at NKU. And what I was interested in is, how do you see the role of the social worker really being an asset to what you guys are doing?
So 60, 75% or more of the social determinants have a big effect on the clinical health, right? So if we can enroll more patients and hand those off to you as a trained social worker that can navigate their needs, whether it could be something as simple as breast pumps, or all the way up to helping someone with addiction treatment therapy, open beds, stuff like that. That allows us to provide more clinical care where we're good at providing the care. And that's why we've hired a full-time social worker at our fire department, because we've seen that need.
Great question. Great question. Yes, sir.
So this question is for everybody, but in particular, Chief Miller. As you guys were doing your analysis of these programs, did you see any threats to the program? Chief Centers, I know that you mentioned that this is not going to be a profitable thing, but as the CMS starts to release money for reimbursement and things like that, do you guys see any opportunities for private companies to try to make a move on this?
They already are out west. So we had a lot of barriers in Ohio, obviously, with the nurses associations, some of the social services associations, different folks like that. We just have to get to the point where there are no borders with care in the field. That we have to all be able to recognize we're all trying to do the same thing, but there's always going to be that inherent risk of you're applying for the same grants I'm applying for, and so that makes me less likely to get it, you more likely to get it. I think we need to get past those things, but basically just tearing down the borders with this stuff, much as we did with the nursing associations in Ohio. I mean, we had to sit down and meet multiple times to say, look, we love what you do, We respect what you do, but we don't want to do what you do. So the people that can use your care and do whatever they do, we encourage them to do that. We just want to be gap fillers. That's it. Wherever there's a gap, that's where we want to fit in.
And just to add to that point, some of the conversations that we've had with the hospital system is they've had private companies approach them about community paramedicine, and because I was one of the first to have that discussion with them, what they realize is that we have a different relationship. I think JD and Chief Sanders, kind of spoke of that, was people trust us a whole lot more because we're the ones that have been taking care of them all these years. We see them at 2 o'clock in the morning, whereas if it's a private ambulance company that's coming in, and nothing against them, but they have their path and their lane. And I think that your residents are more likely to have you come in their home before they have just another company representative come in. So I think that's where the private thing there's a separation between the two of us.
Just think about all the scams that are, excuse me, think about all the scams that are out there for the seniors. This right here gets us into the home.
Yeah, and that's really one of the reasons I asked the question is because anytime, the money is released into the system, the sharks come circling.
Oh, yeah.
So that's definitely something we all want to look out for.
How about a round of applause for the entire family? Introduce a highly educated person managing a massive pharmacy program about community paramedicine. How do you get introduced? What do? You put them in a fire department SUV, and then you put them in a police cruiser. Because that's reality, right? So Neil, thank you very much for being here.
All right, well, thank you. And that was called building suspense, right? So, and you got an extra long break, so hopefully you appreciate that. Was part of the plan all along. But thank you for the invitation, and thank you, especially those of you who presented earlier. I really learned a lot, and even though the title is here, what you need to know, I should be flipping it. Maybe what I should need to know after hearing the opening session. So hopefully it'll be something that you'll perhaps take away from our time together, other than a headache, and you'll learn perhaps some new things about the opioid crisis as well. Kind of my own personal interest in this, as Larry mentioned, I'm the Dean of the Pharm School at UC, but I'm also an active researcher, and this is my area of research. These are a few of the publications just from the past couple years that our team has worked on. And then I'm also co-chairing, along with Melissa DeBella, who's a physician, the UC Health Opioid Task Force. Larry serves on that. Is there anyone else in the room that's on that task force? No one that I recognize, but we actually have about 70 folks now that are part of that. And I'll talk a little bit later as well what's going on with that task force. As Larry mentioned, I did have the opportunity to go on a ride-along with the QRT teams, and that was certainly one of those moments where it really kind of everything becomes real. So those of you that serve in that capacity or do something similar, want to thank you for your service as well. So the next slide I'm going to show you is the most important PowerPoint slide you're going to see today. And that's not trying to offend any of their speakers who might be using PowerPoints. Are you ready for this? All right, here we go. I'm building up suspense too for this. Not that one. Falling asleep in lectures. Okay, so I know it's like mid-morning, so I thought I would just see if we're all at risk. And you might be able to tell from my accent, I'm originally from Canada. And the Canadian Medical Association Journal, what they do around Christmas time every year is that they publish some fake studies, some satire pieces, I think just to see if our physician colleagues are awake or not. And this was one that one of my colleagues, Ken Rockwood, published. And in case you can't see in the back, there's a graph, duration of the lecture, with what they call Noels, nodding off events per lecture. Everybody knows the shape of the curve there as well. So I'll be watching to make sure that doesn't reflect your head by the end of this as well. And you can see how they define a lecture. It's a means of transferring the notes from the pages of the speaker to the pages of the audience without going through the mind of either. All right? So at the end of this, if you come up to me and say, Dean MacKinnon, that was a great lecture, I'll know exactly what you meant, okay? And then also they had some risk factors. So I thought we'd go through these today to see if you're personally at risk for falling asleep during this lecture. First one is dim lighting. I think we're okay there. Warm room temperature, comfortable seating, poor slides, that would never happen. Failure to speak into a microphone. I'm pretty loud, so hopefully that's okay. Early morning, not an issue, but postprandial. So a lot of you have been snacking on the Panera stuff, so your blood sugar is kind of kicking in now, so you might be starting to get a bit drowsy. Monotonous tone. I'm accused of a lot of things by my students, but usually that's not one of them, so I think we're okay. The next one's interesting. Tweed jacket. tweed jacket. And I would have to say, yes, as a male professor, I do have a tweed jacket in my closet, you know, with the elbow patches on. I did not wear it today, so I think we're safe. Losing place to lecture, and then perhaps you'll add to that a lecture from me. So you can assess whether you're personally at risk for falling asleep in the next few minutes together. Here's another one like this. I like this one. Sometimes this reflects my students too. So if you find your eyes are doing this, we call this me doing biochemistry, which is one of our more boring classes. So again, maybe this will reflect to you as well, me during the opioid lecture. So what I thought I'd do is talk a little bit about the magnitude of the opioid crisis. I know many of you are in the field, and you're already well versed in it. So what I thought I'd do is share with you some new studies that have just been published this year that you probably have not seen before. Some studies published nationally, as well as some Ohio data that perhaps as well might be new to you. So again, I suspect many of you know some of the basic stats. And again, this is kind of where we are. You've probably seen slides like this before. A huge public health issue. More deaths than HIV/AIDS at its peak. And so again, something that's impacting all of our communities, whether you're from Cincinnati here today, Indiana, Kentucky, or other areas. So this is a new study that was published just in JAMA, which is one of the top 2 medical journals in the world. Was published just last month. And kind of interesting study. The reason it caught my attention, I'd never seen a study like this before. They looked at overall mortality rates of the entire country for everyone, and looked at the impact that the opioid crisis is having on overall mortality. And this on this map, basically the darker the color, the worse. So look at our part of the country. We're kind of in that worst part, so not on the kind of list you want to be on. And what they found is that overall, the opioid crisis, if you factor all causes of mortality, has actually reduced overall mortality by almost half an entire year. So 0.36 years of life expectancy has reduced life expectancy more than deaths due to firearms or motor vehicle crashes. They also did a state-by-state analysis, and Ohio was kind of in this group of 8 states, where you can see that in the last, from 99 to 2016, opioid mortality-related rates were at least doubling every 3 years. So again, not a list that we should be on. And overall, from 99 to 2016, 351,000 deaths across the country. So I think this is kind of the reason I want to share with you. This was just published last month, and it shows the impact the opioid crisis is having not just on kind of that community, but overall on mortality rates. This is some new data that was published just last month, looking at just in Ohio, and deaths due to overdoses due to different kinds of drugs. Okay. And so there's really, I know it's kind of a busy graph. There's 5 different kind of drug classes in this, going from 2000 to 2017. And these are drug overdose deaths per 100,000 people. So there's a ratio that's been applied. And the first one to look at is heroin. So that's the light blue color. And you can kind of see heroin really flat, flat, flat. Look what happened around 2015-16. And that good news, a bit of a drop last year, but overall certainly a significant increase. Just really in the last 5 years with heroin. The dark blue is natural and semi-synthetic opioids. So this one as well, almost no deaths at all. And you can go up and see that 7.6 deaths per 100,000 people. The next one, the black one though, is one that probably has all of our attention, right? So this is the synthetic opioids. Which drugs are these? Fentanyl primarily, right? Look what's happened with fentanyl. Nothing, 2016, and then is by far the #1 cause of death. Again, so that's certainly, I think, it's a one. Psychostimulants, again, almost nothing, and then there's a bit of a jump in cocaine as well. So if you look at this, again, not a great picture here in Ohio. Doesn't matter which drug category you look at, not good at all. And then kind of just breaking it down, the stripe bars are Ohio, the dark is the US average. So again, kind of the same data that I just showed you, but kind of showing in a different way. So again, if you look at heroin, 9.2 deaths per 100,000. Across the country, 4.9. So you'll notice that for every single category, Ohio is higher than the US average. And the black line is the death rate due to motor vehicle crashes. But again, synthetic opioids are the one that really stands out as being kind of the one that grabs your attention.
Neil, why Ohio? I-75, I mean, what is it?
Right, yeah, and certainly some of you are in the field probably have other reasons. For those of you that did anybody attend our symposia that was 3 weeks ago? So a few were there, so certainly, our keynote speaker, John Sprague, he had different hypotheses, things that he's seeing, kind of working with the Attorney General's office, and part of it is the drug trade routes and kind of Cincinnati, Dayton kind of being the heart of that. I'm going to be showing you a short video in a couple of minutes, looks at, anybody from Montgomery County here? So actually a short video that really goes to some of the reasons why Montgomery County. Again, this kind of shows, again, the same data, just different ways, state by state. So you can see heroin were the 7th, I guess 6 DC's up there, 6th worst state, 7th overall. Synthetic opioids, number 5. Synthetic opioids, number 2. So only West Virginia is higher. Psychostimulants, top 10. And cocaine, number 2. So again, it really shows kind of where we are in the country. And again, not where we want to be as far as on those lists. Ohio, as you know, has the second highest death rate due to overdoses in the country. And this was the month of January. In January, Hamilton County reported more than 150 overdose cases. So that's kind of the state perspective. If we drill down to Hamilton County, how many folks are in Hamilton County here today? So many of you, like myself, I live here as well. Some good news, I guess. Overdose deaths were down from 570 in 2017 to 440 last year. A lot of that might be attributed to the widespread dissemination of Narcan. I know many of you are involved in that. I think that's really had. I know just at our symposia, Hamilton County Public Health dispensed over 200, and people were coming off the street to get it, so it was really neat.
I now carry it in my car.
There we go. All right, there we go. So some good news. Is anyone here from Northern Kentucky? Okay, so Northern Kentucky, I couldn't find kind of overdose rates, but St. Elizabeth, of course, which is pretty much the only healthcare system that publishes emergency department visits related to opioids. And you can see that the change in 2011, 252. 2017, almost 9 times that, over 2,000. That dipped in 2018. And there was an article recently in the Inquirer that kind of talked about that, almost the same question you asked, Larry, kind of in a different way. Why are we seeing an improvement? And then again, they kind of attribute that to, part of that's Narcan distribution, just better kind of maybe community awareness as well. So some good news, I guess, maybe locally in Hamilton County and Northern Kentucky, but is this too rosy of a picture? May your life someday be as awesome as you pretend it is on Facebook. Are there other kind of problems still going on? And so I'm not sure is the video ready? Okay, awesome. So what I'm going to share with you, because this really kind of got my attention. This is a video actually I taught last week with our pharmacy students on the opioid crisis, a short video that I shared with them. So it was published by the New Yorker magazine, and in my slides, I don't know if they're going to be available. Certainly.
Yes.
Okay, great.
All you do is send me an email, and I'll send them the slides.
There's a link to the
cards on that handout.
Yeah. So the New Yorker did a photo, what they call a photo essay, on the opioid crisis, and it focused on Montgomery County. And the pictures are riveting. But as powerful as they are, they actually kind of behind the scenes. The video you're going to see is the photographer from New York who flew to Montgomery County and took the pictures. And this is a short interview with him. So again, it's not a healthcare professional, not a first responder, a photographer, right, for the New Yorker. And you can see the impact of just spending a few days with first responders, paramedicine in Montgomery County, and how that impacted him personally. So it's really powerful. I thought I would share that with you.
We got a call on the first day of my ride-alongs. It was on this very normal suburban street. When I exited the car and walked up, I could hear agonizing crying from down the street. When I approached, I kind of came across this really incredibly heartbreaking scene of a family in mourning for their son who had just overdosed. It really was one of the harder photos I've ever taken. The family eventually reached out to me and invited me to the funeral. Felt really honored to be there. Everyone had a story to tell about personal addiction or knowing someone obvious place to turn to. When researching for the story, I had heard about the coroner's office in the city of Dayton. And the coroner there had basically been running a room for bodies that were coming into the coroner's office. The coroner was at capacity with COVID. He's speaking very candidly about it. More and more I researched, I realized that this county, Montgomery County in Ohio, had the highest overdose rate in the country right now. That, to me, at least, seemed like Winston. We were on non-stop rentals, doing 2 shifts, some days only taking opioid calls. One of the more memorable calls was actually my last day. We got a call for overdose in Monroe, and this police was on site. It was
Yeah, I apologize for the sound there, but you've got the link on my PowerPoint, so definitely take a look at it. The photographer here, who's actually his name is Philip Montgomery, so going to Montgomery County, just chronicles again that week spending with first responders. And I think for me anyway, that kind of humanizes it, and you can see how his eyes were open with that experience. A few other things kind of just going on related to the crisis. One is kind of, I think a lot of people are asking, what's the role of drug companies in all of this? And as you might be aware, currently our governor, Mike DeWine, was the attorney general before. He had actually, in that role before he became governor, started a lawsuit, and so hired Mike Moore. Mike Moore is not Michael Moore, so Mike Moore. Mike Moore is an attorney who led the charge against the tobacco companies and then British Petroleum for the Gulf of Mexico oil spill. And so has had some success in the past on those lawsuits. You can see a quote, Purdue Pharma created an environment so that opioid use was okay. So if you prescribe your patients this drug, there's less than a 1% chance they'll get addicted. That was a big, big lie. And I have a link there to 60 Minutes. They did a show in December that kind of interviews our governor, interviews Mike Moore, and kind of talks about their strategy with the lawsuit. He goes on to say Ohio's losing $4 to $5 billion a year from the opioid epidemic. They're losing 5,000 to 6,000 people a year from overdose deaths. So when a jury hears the evidence in this case, they're not going to award just a couple $100 million. It may be $100 billion. And Governor DeWine says they flooded the state of Ohio with these opioid pills that they knew would kill people. One year we had close to 1 billion pain meds prescribed in the state of Ohio. That's just incredible. Enough for 69 per person. And that lies at the feet of these drug companies. So the lawsuit involves drug companies. It also involves McKesson. Has anybody heard of McKesson before? And they're actually the bigger fish to fry here because the drug companies are worth billions. McKesson's actually worth hundreds of billions of dollars. Any thoughts on why McKesson would be involved in this? A drug wholesaler.
The distributor, the reps.
Right, yeah. So they could see all the trends. So basically anytime prescriptions are written, pharmacy fills them, McKesson's the one delivering those drugs, so they could see what was going on. And so that was kind of the thought, is that for years, these huge, incredible quantities of opioids being dispensed, and McKesson, fills the orders for pharmacies, but doesn't do anything to intervene. And so that's why they're actually kind of the bigger ones. Interesting, at this time, prescribers aren't in the lawsuits or pharmacists, but certainly, so a lot of people several states are involved in this initiative, but Ohio really is one of the leaders. And I think this is kind of the situation as well. Perhaps prescribers have a role. Try this, I just bought 100 shares. What was the role as far as kickbacks and those sorts of things as well? I actually had just kind of had an ethical situation as a dean 2 weeks ago. One of our alums who was a pharmacist in Florida passed away. And so unbeknownst to us, he had left the university in his will. Well, he had been convicted 5 years ago in Florida for working with physicians on a pill mill and had dispensed over 1 million prescriptions for opioids. And so the ethical dilemma is, do we take his money or not?
Take the money.
Yeah. Well, we put it with the university lawyers, so it's their decision. But I mean, that just, I mean, to me shows kind of the challenge, how far reaching it is. So you might be asking, okay, is there any evidence showing that when drug companies target physicians with marketing for opioids, is there any kind of outcome? And we really didn't know that until actually just last month. So another study that was published in JAMA, these researchers looked at this. They looked at marketing between the years of 2013 and 2015. They found that drug companies, for certain physicians, spent about $40 million on marketing opioids. And what they found is two things. Physicians that received more marketing did prescribe more opioids, and also in those parts of the country there were more opioid-related deaths. And so this is, I think, evidence I'm sure will be in the Ohio lawsuit coming up as well. All right. Well, if I ended the presentation, this would be the most depressing presentation in history, right? So I think we all, we're aware of the challenges. I wanted to share with you maybe some new data you haven't seen before in our new studies. Well, let's move on to solutions and how can we combat the challenge. And I think for many of us, we're kind of struggling, what seat are we in as far as, are we actually feel like we're causing change, or is it something that's just so overwhelming it kind of consumes us and we're just kind of along for the ride? And so I think a lot of us, this is the challenge. So I'm going to start kind of nationally and then work down locally. So nationally, certainly has been, the Trump administration has focused on it. Just in January, the National Drug Control Strategy was released. How many folks have seen that? Not a single person. Okay, so there might be something to look at. In there, the reason it's important is because this is going to drive where federal funds are directed moving forward. And they focus 3 key areas. Now, these are fairly broad areas, probably not a surprise to anyone here. The first one, prevention initiatives. The second one, treatment. And the third one, law enforcement in reducing access to opioids. But that, again, this will really draw as far as where local funds, state funds, will be coming from.
Yeah, and this HHS prescribed.
Right. Yeah.
Right in there.
That's right. Yeah. So again, that's kind of the national level. Also, the Department of Health and Human Services, they have, I won't read them, but 5 key priorities that they're focused on. And then on the research side, as I mentioned before, I'm a researcher. A lot of new funding and effort provided by NIH continues to happen
I
as
ask you
well.
a question. What about, I'm with the MAT crew, what about the people that lived this and went through all of this? What are you doing to help the people after that? The people that has issues with the lawyers, issues with housing,
Sure.
issues with working, what
Yeah.
about those people? We lived through that.
Yeah, no, and you're,
So what could
right.
we get out of
And
it?
your role is definitely critical, right? I mean, you're part of the solution. I can't say explicitly, if you look at the National Drug Control Strategy, I don't think they delve in that kind of level of detail, although they certainly say prevention, so how do you prevent relapses? Because we know it's a lifelong condition as far as drug addiction, right? But I don't.
28 days.
Yeah, no, exactly, yeah. But we'll talk hold on thought, in a few minutes I'll talk kind of locally what we're doing with the Opioid Taskforce as well. So that's kind of nationally. At the state level, I'm going to pull some stuff. This is an article we wrote in 2017 where we looked at the state of Ohio and what are they doing to address the opioid epidemic. As you know, Governor Kasich was certainly very engaged in this. He formed what was called the Governor's Cabinet Opioid Action Team, so GGOAT. And within that, they've done many different initiatives. I'm going to kind of highlight a few of these. When Governor DeWine assumed power, he's kind of reorganized. It's now called Recovery Ohio. Tomorrow, I'm going to Columbus. I'm meeting with Alicia Nelson, who's the head of this, so I can't tell you a whole lot until after tomorrow. I'll know more, but meeting with her in the afternoon, and they've actually just released some documents publicly as well with strategies. So some things, what are they doing in Ohio to address this epidemic? Part of it is prescribing guidelines to make sure that, we're not trying to stop all opioid prescribing. I had rotator cuff surgery this fall, and believe me, I needed those opioids right for the first 2 or 3 days, so it's not like no opioids, but certainly if you look at the data, it's been overprescribing in the past, and so the state has implemented guidelines. Now guidelines, you could say, do they really work or not? And so one grant that actually I received from the Ohio Department of Health was looking at the prescribing guidelines for emergency departments and hospitals, and we looked at did they actually make a difference or not, so I'm going to share that with you right now. And so for part of this, We did interviews with emergency department directors across the country. And just as a side note, I'll tell you, I do a lot of survey research. I've never in my life gotten a 92% response rate. And these are some of the busiest people on the planet. You think of emergency room physicians and directors, right? And for them to have to take the time to do our interview, I think really speaks highly as far as the importance of the issue. And it's kind of a busy slide, again, that will put you to sleep. I'm not going to walk all the way through it, but these physicians, they did say these guidelines help them use our prescription monitoring program more, but most importantly, number 2, 71% they felt it did reduce inappropriate opioid prescriptions. So the state is implemented guidelines. Ohio is a leader in this area, and so the idea again is that we're more responsibly prescribing opioids. We also kind of did a really deep dive with 20 individuals. These were over hour-long interviews, and I won't share kind of everything. One thing was kind of this is kind of the challenging part. Sometimes in our healthcare system, we do things that are kind of counterintuitive. As you might know, those of you who work in a hospital environment, hospital reimbursement is tied to HCAP scores, part of it. HCAP, of course, are the discharge patient satisfaction scores. And so one of the metrics on that is basically pain control. So if you think of it, if hospitals are providing better pain control, they're going to get higher reimbursement, which often goes against, should this person really be receiving an opioid or not? And I think that's some of the frustration is sometimes in our healthcare system, there's things that, it really doesn't make sense. Why is one system kind of rewarding prescribing while we know, again, that we really should not be doing that? So some of those things came out in our interviews. House Bill 341 in 2004 created ORS. Has somebody heard of ORS before? Okay, so certainly you might have some prescribers in the room. It's kind of a love-hate thing. I think the amount of fields and time it takes to do it can be a time suck. At the same time, these programs do provide some value. And so we received another grant basically saying, did ORS, is it working or not? And so this was published in Drug and Alcohol Dependence last year. And you can see just by the shapes of the curves, it has had a dramatic impact. So this is kind of a success story for Ohio. We've seen a large decrease in the number of opioids and benzodiazepines that have been prescribed. And so many other states are kind of actually looking to Ohio as an example in this area. Some other things, Ohio Bill 93 strengthened laws to prevent pill mills. Unfortunately, we had a lot of these, especially kind of in the southeast corner of the state. So licenses of 61 physicians and 15 pharmacies have been revoked that were part of that pill mill process. So I think that's a good success story. Some changes to workers' comp and reimbursement as well. And then probably one of the more visible ones is just trying to increase access to naloxone. And I know many of you are personally involved in dispensing naloxone and ensuring its access. Pharmacists and traditionally in the past had not really been that engaged until 2015, when essentially now they could dispense naloxone without a prescription under a physician-approved protocol. We received another grant basically to figure out, did it actually make a difference? And I'm presenting on that on Saturday in Seattle, so I actually am sworn, I can't tell you by the state law until that gets presented, but I'll send Larry the poster presentation from that, so you'll have that. Interesting though, this fall, 2 other states where that's allowed, California and Texas, they found actually there were still a lot of barriers. And if you think of this, has anybody been around someone who's been administered Narcan? Okay, is that a fun situation? Do they wake up and hug you? No, right? And so I think that's part of the challenge too, is that in that situation, especially if that's happening in a pharmacy, it can be disruptive to the staff, other customers in the pharmacy. Usually, the person might throw up or other fluids in the floor. So for some pharmacies, unfortunately, it's a bit of still the stigma part. We actually kind of saw that in our interviews with emergency room directors as well, the stigma that still goes with this as well. So certainly in California and Texas, there's still some struggles, even though pharmacies, again, are allowed to dispense it. Many are choosing not to because of that. I'm going to skip the slides for time. Good Samaritan law was passed as well, and then some other laws allowing pharmacists to do more in pain management. So locally, how many folks are kind of in Hamilton, kind of local area? I think I asked this already, but I was just testing you to see if you told the truth the first time. So Larry's part of this initiative. This is was formed 2 years ago. It's a UC Health Opioid Task Force. It's interesting because yesterday, as mentioned, I presented at Hamilton County Public Health, and Tri-Health has a task force, and Mercy has its own, and Christ Hospital, I think, and we're trying to make sure those efforts are coordinated. Again, that's Melissa and I and some of the members of that task force. We have 4 working groups, one around research, and this should be a kind of an encouraging thing. We have actually some of the best research in the country going on right here in Cincinnati. There's a group called NIDA, which is the National Institutes for Drug Abuse. One of their clinical trial hubs is here in Cincinnati. Teresa Windhusen is the chair of our research working group. She has about $20 million in NIH funding, and so some really good stuff happening right here locally. What's been really cool too, and Larry's been to some of the meetings, this has been one of the best parts of the task force, is UC is a huge university, 46,000 students. UC Health is a big health system. We have people in the room at this task force that have never even met each other before, and they can't believe that someone else is working on the same project that maybe that they, or how they could partner together. So we've had some really cool research collaborations that
Thanks to the task force, I met Dr. Rick Ryan.
Yeah, there you go.
He presented last year in this room.
That's right.
And he presented on Monday at Coleraine Township.
And Rick Ryan is an amazing guy. I mean, just so he's actually skip down. He's one of our practice co-chairs. As you know, he's very public. He was he's had a former addiction in the past, or and still kind of working through that. But emergency room physician, Christine Wilder and Stuart Wright as well. So they're the practice. So we're trying to see how can we provide better care to patients. Education, Kelly Lau's the chair of that. Our goal, we have actually 4 health colleges at UC. Pharmacy, I'm the dean of that, medicine, nursing, and allied health, which includes social work, occupational therapy, 16 different programs. Our goal is that every single student will leave UC knowing how to address the opioid crisis. And this sounds like kind of maybe a minor thing, but it took 8 years to put together. This semester, for the first time ever in the history of UC, all P1, so first year pharmacy students, are taking a class with all M1 first year medical students on collaborative team care, and they're using opioid crisis and pain management as kind of their major thread throughout that. And so that's really exciting. We're hoping to add nursing and social work and other disciplines in coming years. And then finally, community outreach and engagement as well. We have a huge inventory, this about 50-page document of activities that team members are doing, and about 70 members of the team. I won't read through this slide, but it kind of shows some of the activities that we're doing. Some of these have been outreach, so we did a research symposium in 2017 that kind of highlighted some of the research going on. And then just, about 3 weeks ago, we had about 250 people learning about the crisis with different tracks in that. So again, Larry was at that event.
And one of the impressive things was that the Hamilton County Public Health had their van out front.
They did, right, yeah.
And I didn't realize, I thought if you came with your needle, you've got 1 needle back. No. If you're the needle collector, you can come in with 30 and get 30 fresh needles.
That's right.
That was eye-opening.
Yeah, they have a key role to play locally for sure. I think part of it for us has just been kind of getting the word out, and it's kind of maybe a strange slide to put up here, but one of my best friends was in England 3 years ago, took this picture, and we're looking at the pictures on the phone. We couldn't figure out what this meant, so if you know what this means, let's talk afterwards. But we wasn't sure, does this mean you can't hold hands? No fathers with daughters, no short and tall people together. We're still not sure what it means. So I think in life, you want to be able to communicate your message and stuff. Here's another example of that, where communication could be a problem. And so for us, a lot of this has been getting, just like today, so thank you again for the invite. President Pinto, UC's president, in his State of the College, or State of the University address this spring, included that. The College of Medicine has been doing a lot of kind of PRs. This is Mike Lyons, who's an emergency room physician. His research is in the opioid crisis. We had Tom Seiden at the university, and last year for the whole university for research, it was one of the 4 areas that was kind of highlighted. A lot of it currently has been kind of political outreach as well, so political leaders. He's no longer in the Trump administration, but Secretary Shulkin with the VA, he had spent a day and a half in Cincinnati as well as we discussed the opioid crisis. So our next steps of our task force almost kind of falls to your question, like what are we doing locally and what should we be doing? We've asked each of the working groups, actually Jason is here, who's part of our kind of a leadership team as well, looking at kind of what are the needs, how can we address this need better in the Cincinnati area? So again, whether it's research, whether it's education, or providing direct patient care. And we have one pilot project going on right now with UC Health that's trying to, with folks who are who arrive at the emergency department, are treated there, then what happens, right? And so this project has been really trying to make sure there's linkage, there's follow-up, that continuity of care that often gets missed with that. So that's
in fact, Dr. Ryan on Monday shared that those patients are now getting placed within treatment centers within 24 hours.
Yeah, and Dr. Ryan's been the lead on that. Yeah.
Unreal.
Exactly. I think our video's down, so I'll just, and I think many of you know Tom Side anyway, but I think something we should feel good about it as a community. USA Today in January did a whole feature piece on Newtown Police Chief Tom Side. And
just Google him, you'll find.
Yeah, he's kind of a local hero, but what I really, the reason I wanted him to speak to my students, which when we brought him to the college, is you can just see from the second he starts speaking the compassion and how it's impact. He's seen entire families wiped out in Newtown. I live kind of on the edge of Newtown and Anderson, so I drive through Newtown every day. Of course, it's a speed trap, but drive through it every day. And again, the audio is not really working today, but if you would take a look at that video, it's really neat. The last thing I thought, I'm going to keep this fairly brief, but since I'm a pharmacist, I know we've had kind of interesting. A couple of the speakers on the panel this morning mentioned kind of working with pharmacists. Sometimes pharmacists, people don't really understand what they do. And so these are some drawings by school-age children, and so they were kind of asked what pharmacists did. And this first one is my kind of pathetic reproduction of the rest of the actual drawings. And so this one was a 4th grade. You can see this tall counter. So if you think when you were in 4th grade you were shorter, the pharmacy counter probably looked a lot taller. This big balloon coming out saying that will be $5 and all these different bottles. So what's missing in this picture? There's no pharmacist, right? There's no one in this. So that it's kind of like, oh, that's not good. So here's another one. This is Steve, and a very different pharmacy. You can see Steve sitting on a stool crying, which is not a good thing. You can see just syringes laying around, and what do you see over here? The cash register wide open, and this pharmacy's raking it in 1s, 10s, 20s, and 100s right there as well. So again, probably not exactly what we want as a pharmacy. I like this one here. Okay, so at least there's somebody in this one, and they're saying something. And I think the pharmacist is having a bad hair day there in that picture. I like the smelling of pharmacy too. So it's a little bit better. At least there's someone in there. And this one I really like. Jasmine, she says, the pharmacist saying, "Here's the medicine for your cold, sweetie." And she's saying, "Thank you." So this one's nicer. And I like this one. Look at this, Judy. She's actually the employee of the month. So that's very good. Looks just like her there as well. So that one's better. And that's my favorite one. This is Chandra over this. She's 12. It says, "A pharmacist is a person who I see as being a good person. I get medicine from him or her that helps me get better." And we know that just like in your profession, sometimes you face stressors or things. Sometimes this happens as well to the pharmacist. So again, the video link isn't working, but the video, if you check it at home, there's a pharmacist in Youngstown, Ohio, that was working with law enforcement to basically identify a pediatrician who was inappropriately prescribing and selling opioids. And so I think there's that side sometimes working with law enforcement, but I think certainly we train all of our students to do this at UC. They want to be part of the healthcare team addressing a crisis, and we know that the opioid crisis really is the public health crisis in this country. And so I think pharmacists are more than willing to be part of those teams. Again, it was encouraging to hear this morning kind of two teams that have done that. And lastly, I'll just end with this as well, our own students. So Jen Shear, she's actually coming with me to Seattle to speak, and she organized an event with Halbert House, and they distributed over 100 free Narcan kits. That was a student idea. I had nothing to do with that. I take no credit as their dean. They organized that. They set it up, and I think students are really, really pumped. So I know we covered a lot here. I'm not sure if this is what you feel like, way too much information. I know it was a fast thing because I'm trying to get you back on schedule with the program. But I really appreciate the time together. And just end with this quote, C.S. Lewis, "You can't go back and change the beginning, but you can start where you are and change the ending." I love this. This so applies to the opioid crisis, right? So, we've got this huge crisis devastating our communities. We can't change the beginning. Sometimes there's parts of it we can change, but I think all of us in the room would work together to hopefully influence the ending.
So, question?
So, yeah.
That's a great quote. I got a lot. I went to the event.
Oh, great.
Yeah. And what I've seen, like the students are great. I mean, I can email a lot of your students. But I'm Terrence Wilson, and I'm the voice of MAT support community. You know, MAT is the standard now. And what I noticed was when I met these students, they really never seen the crisis.
Right.
And what I noticed about the first responders and the doctors, you see the beginning, you know, and it's like that. And you never see the end.
Right.
You never see y'all work, y'all hard work on the positive side. And y'all, these are success stories on MAT.
Yeah. All right.
And that's how we kill stigma. Right. And we go to a lot of these events, and you almost said it.
Yeah.
Peers are huge.
Yeah.
And my business proposal is at Alicia Nelson's desk right now.
Yeah.
Because they know support is needed.
Yeah.
And what happens is that now that MAT is gold standard, they have nowhere to support and the community to go share or go talk. And we were always taught as kids to talk about it, it'd be better.
Yeah.
And what happened was they started getting better. And I tell them, even though I wasn't on MAT, I'm the voice because they need it. And you guys are doing, I go to these forums and these summits, you guys are doing so great, it's great work. And I come back and I tell the group in the meetings, we have a meeting in this room right here, MAT, and I report back to them. And I think what needs to happen now is we need to report back to y'all and tell us what's needed out here.
Right.
Because y'all never been out here, and that's cool. Don't come out here, I mean, don't go through it.
Thank you.
But just come to the ground, I mean, ask us. And they'll tell you what's needed, because everything y'all doing, the scientists, the doctors, the nurses, the healthcare. I remember a couple years ago, our kid was like, no, we're tired of it. Now it's like, let's do it. So it's growing. But it's that last piece that's so important, because then I work in clinical outpatient and clinical inpatient. And what I kept seeing is relapse. And I asked myself why. And it's just, they don't have nothing after the fact of treatment. That's it. I mean, there's resources, but they won't follow you. They'll follow us. Because, you know, first thing we do is try to, hey, you don't look like us. You ain't been what we been. That's what we're going to do first.
Yes.
And what we're trying to do now is to kill stigma. The only how we can kill stigma is to show the end result of how we do recover. It do get better.
Right.
When you see people get their kids back and get their first cars, credit score. It's just as hard in America without the drugs. You know what I mean? And we say, all right, treatment, more treatment. Treatment is needed, but then ask us what we need. And I will report back to you, because we can't go to AA.
Right.
Okay, they said you're not playing, so they got their own group. But we got to get the word out there because more people need it.
Right.
The medication assisted treatment, I tell them all the time, it's not the rate of the pill for the patient. It's not recovery, but you got the medication covered with counseling. Now we got to add the community peer support, because AA can say we live in lives forever, but these people are shut down. They say they don't talk about it.
Well, appreciate speaking up, and love the t-shirts, by the way. So thank you for wearing those today. I'll say now you've got an open invitation anytime you want to speak to our students and talk about the key role you play. I would love to have you. Our students need to hear that. So Larry has my info, so feel free to reach out.
Send me an email.
And certainly I know my other co-chair of the task force, Melissa DeBello, that's her world is more the clinical as far as partnering, and they provide that treatment at UC Health as well. But I think the reintegration into the community and like I said, those small wins like credit scores and stuff, we kind of forget about. We kind of just focus, but the concept of health is broader than just a disease as well. So
but it's needed. I mean, you guys, the more you grow, we save more lives. But how do we sustain and make long-term recovery?
Right.
You know what I mean? So many dollars going back and people relapse 5-7 times. It was missing. And while y'all growing, we growing, and it's like let's all just move as one unit. Clinicians do a great job. I mean, Cat House, great job. But it's not too many places that people in recovery will send you because they don't do a great job. So it's like, nobody always full because we tell people go. That's where you get good recovery. You got no stigma, so just ask us sometime and we'll let y'all know. It's just one question. Hey, what do you need out there to make it? What's going on?
God bless you.
And thank you. It'll be solved.
How about a round of applause for the dean, huh? All right, my friends from the Cat House, come on up, all right? But I want to share an experience in this room. And Barb, you were part of that experience. Barb invites me to come down here on a Saturday morning. And she's getting hugs from all of these folks in the room, some of whom had their children here. And these folks in the room were then headed out to fire departments to hug their medics. Who were they and what were they doing?
They were former clients, they were mentors, they were alumni. And what I found out, my husband and I did a training with some first responders a couple years ago. And what we took away from it was that they only see the ugly side. We were asked point blank, does Narcan work? And we're like, well, of course it works. But they had never seen what happens after the Narcan. So what we do, and we've been out, I think, like 5 times now. We'll be going out soon now that the weather's breaking. We meet, we go, we break up into groups, we go to area fire departments, police stations, with people who have been Narcan, who are living a life in recovery, and just to thank them for what they do and show them that it makes a difference. And it's been, I think, very impactful on the places we visit, and certainly on our clients, on our alumni and mentors as well.
It's been amazing.
Yeah.
Absolutely amazing. And many of the firefighters have allowed you to take photographs of them being hugged, and it's wound up on your newsletter and elsewhere.
Absolutely.
So thank you so much for doing that. And all right, would you all introduce yourselves, please? All right.
Well, we were just going to
spin you around. Right here.
We were trying to get everybody kind of back on track, so we were just going to make ours a little bit more abbreviated version. I'm Michelle Pritchard. I'm the Director of Clinical Services. So I've been at CAT for about 7 years now. It'll be 7 years this summer. I interned here when I was in grad school, and then I just was hired on as a counselor. And then so I've been the director for almost 3 years now, and so I'm the director over all of the counseling areas. So that's inpatient, outpatient, medication-assisted treatment, mental health counseling, all of that. So I'll briefly tell you what we do. And then I'll have you talk to our peer mentors and our alumni, who, those are the people we really want you to hear from. Those, you see all the statistics and the research and the data and all that stuff, which is great. This is wonderful. I love education. I love training. It's important. But hearing their stories is what is so powerful, and what I want you guys to leave with. Mike, we'll have Mike introduce himself real quick, and I'll tell you about it.
I'm not going to add a single thing, just that I see some familiar faces in here, and for those familiar faces around the room who have been very personal in my own training, I want to thank you, and it's great to see you back. I started here about 10 years ago, and kind of through my journey, I've really fallen in love with the population that we serve. They teach me every day, and with that, then it renews me. It gives me so much pride and so much hope. Not just for individual stories, but really for our society, that recovery is possible. And I think you'll hear testimony of itself right here.
Well, I'm Barb. I'm the recovery coach here at CAT, and I have been with CAT informally since 2006. So as a recovery coach, I'm a person in long-term recovery, which to me means I haven't used a drug or alcohol, any substance, since November 12th, 2005. So in 2006, I was asked to get involved here, volunteer. I was never a patient at CAT, but the Alumni and Friends Association is just that, alumni and friends. So it's something that I got involved with, I stayed with. I became a mentor when we started our mentor program in 2013, and joined CAT as an employee in February of 2017 as a recovery coach. So what I've been working on is growing the mentor program, giving some stability to it. And what we do with the mentors, they work one-on-one with our residential clients. They also go out in the community and advocate, reduce stigma. We've recently added, and I guess you'll talk about this, inpatient medication-assisted treatment. So we've also added, now we've bridged that gap, and we have MAT mentors. We have medication, people who are mentors with experience in that realm also. So I'm going to quit talking. I want to introduce you to a couple of our mentors who, their story's amazing. So who wants to go first?
Okay, I'll briefly just, you guys can prepare. They weren't prepared. I'll briefly run down our services. You guys can decide what who wants to go first? So like what Barb said, we have the inpatient treatment, we have the detox program, so we're one of the only people in the area outside of a hospital setting that provides the medically monitored detox program, where we have on-staff nurses 24/7 to monitor that person's condition and provide comfort medications for the individual to make sure that they're having a safe and comfortable detox. So we detox, of course, opiates, alcohol, crack cocaine, really any substance that that person needs detox from. We also have the residential program, which Barb had mentioned. Those two programs are what we've had for forever, as long as CAT's been open. So that's about 30-day residential program. And now we have the option for people to take a different track or a different pathway, the buprenorphine. So they can use the buprenorphine for withdrawal management, and then they can also use the buprenorphine while they're in the residential program. So they continue the maintenance medication if that's a pathway that they decide they want to use. We also have outpatient services where we have continuing care. So people, once they finish our residential program and they want to continue with us afterwards, it's a 12-week program. It's a group. It's once a week for 90 minutes each week. After they finish that, then they're eligible for graduation following that. So they're usually about 3-4 months sober by the time they graduate, which is awesome. And we also have other outpatient services. We have medication-assisted treatment, which has been talked about quite a bit here, which is buprenorphine, Vivitrol. Those are the medications we use there. We also have outpatient mental health counseling. So that's a new service for us, where we do couples counseling, we do gambling counseling, we do anxiety, depression, PTSD, really any sort of condition that the person experiences, as well as substance use conditions. We provide mental health counseling for that. We also have our new primary care clinic. So that's not just for our patients, but we do serve a lot of our patients. That's for anybody in the community who needs that additional care for primary care. We also provide that service. And so, do you guys decide who's?
Paige is going to start.
Paige is going to start. We have Paige here in the middle who wants to tell you a little bit about herself.
Hi, my name is Paige, and I am an addict. My clean date is September 9th, 2018. So I have 6 months, 10 days, which is the longest time I've had not using drugs since I was 13 years old. So I'm really proud of that. And I'm also an opioid overdose survivor. If it wasn't for Narcan and first responders, I wouldn't be here today. So I'm gonna talk for like a second about that, I guess. So on December 23rd, 2017, I was found unresponsive in my car. And thankfully, someone found me, I guess, and I was unresponsive and just breathing once a minute. And all I remember is my drugs. I was a heroin addict. I was using heroin, and all I know is I woke up in an ambulance with about 4 heads standing above me, asking, like, can I hear them? Am I okay? And and I was angry. I was angry at them. I was not thankful to be alive. I was confused, and I was hostile, and fighting with them of like, well, why did you bother me? Like, why did you interrupt my like, why did you wake me up from my high? Because I was high, They're like, no, you weren't high, like you were dead. And but at that time, I couldn't understand that. I couldn't understand why they cared more about my life than I did about my own. So that was December. So in March, I started to get clean. I tried to go to rehabs, and I would come out and I would keep using. And then I ended up here at the Cat House. July 17th, I checked in. I did, a detox for like a week, and then was here for 37 days. I love this place. I love, all they do for me. I did finish the inpatient program. I'm in a sober living house. I completed the 12-week aftercare. So I graduated. I'm an alumni. And I also took the peer mentor class, so I'm a peer mentor, so I come in here and talk to other women like in the program, and I'm just like trying to be supportive and trying to show them that like we do recover, and like I've been in that state of like hopelessness and not wanting to live, and like today like I want to live, and I want to if the one purpose I have is to like give hope to like one person, then that's like good enough for me. So I can't say enough about Narcan. I've lost 10 friends from overdose since 2014. So why I'm the one that made it, I'll never know that, but I'm forever grateful for Narcan and those people. My sober living house, we have I think it's a rep from Hamilton Public Health. They come, and there's 12 girls that live with us, and they distribute Narcan to all 12 of us girls and teach us how to use it. So we're out here in Cincinnati with our Narcan like in our purse at all times, and we know how to use it and what to do. So I feel like we're like on the front lines of like really trying to save us, because there is life after there's life after that moment. I know you guys always see the bad side of of us being not happy about being alive, but since then I am just so grateful. So I just want to say thank you.
So my name is Ryan. I'm also an addict in long-term recovery. My sobriety date is January 25th, 2018, so I'm working on 14 months. So even with the Good Samaritan law in place, so I had gone out because it was Black Friday morning, and obviously the drug dealers were sleeping in, so I was just basically on a dead mission, and I was over here at McDonald's on Martin Luther King, and so I meet some strangers who weren't able to get their methadone at the clinic across the street because they had other drugs in their system, so we started driving around, and so I've just met these people like 10 minutes ago, and we're in the car, and so we end up getting some drugs, and knowing now it was fentanyl-laced heroin, but what looks the same, and it wouldn't have mattered had I known, the outcome. I still would have done it. But so we do the drugs, and I fall out, and they kick me out of the moving car going down Martin Luther King right there, right outside the Dunkin' Donuts on Vernon. And luckily the lady whose yard I'm laying in, luckily called the paramedics for me, and people came and they Narcaned me, and I'm very appreciative of that. And at the time I wasn't, though. At the time I was, you just blew my high. Get away from me, you're disoriented. The police are like, you can go with us, you can go with the paramedics, take your pick. And I'm like, well, I'll go to the hospital. And then I, MAA or whatever, against medical, advice at the hospital as soon as I can to go get more drugs. But, my mom is thankful, and you will never hear that from her, but it's true. My 94-year-old grandma is grateful and appreciative, and you'll never hear that from her. But when you save one addict's life, you're saving, a whole family and a whole network of friends and people. It's not just a person in the moment. And also something that really has always stood out to me when I was homeless, I would read the paper all the time, and I came across an article where first responders were suffering from compassion fatigue. And I never thought about that phrase or what that really means. And basically, I'm sure you're all familiar, you took these jobs to save lives, to be the hero, and you spend all day going from call to call Narcanning ungrateful people. And, I apologize for that, but you're planting the seed with each, and they might not get it today, and they might, never get it, but, you're doing your part, and you are making a difference. And the other thing that I was talking about, Terrence, within the parking lot, if you're like me, I passed at least 3 homeless people on my way here, panhandling money, flying signs, out there trying to feed their addiction. But if I didn't speak, if Paige didn't speak, if you didn't meet any of us in this setting, you would not know we're recovering addicts. So you see us at our worst, you see us when we're a drain on the community, but then hopefully if we get our lives together and we start to make positive changes, we just blend into society. So it's not as noticeable of an event when there's people out here successfully, living their lives off of drugs and after Narcan and after, your guys' interaction in our life. So, I mean, obviously I didn't get clean. I would like to say that the day I got Narcan, I got clean. I didn't. I got arrested several more times. I did, drugs for a lot longer, but had it not happened when it did, I wouldn't be able to have finally gotten the message to finally be here today. And I don't know, there's always people in these rooms that have connections that we don't see. So just some things I like to say. I feel like in the future, if we could have somebody like a way to transition from a jail, like it got to the point where I was going to jail on purpose trying to get help and I couldn't. And a non-violent offense will have you back on the street in less than 24 hours, and that's not long enough. Like I will then get high again. So if I would have been able to come straight from the jail to a treatment facility, things might have made a difference. And even when I was out there and I had made a decision, it took, 28 days of calling the cat house every day, because you have to look at it. I'm on the street. I have no cell phone. There's one payphone in the city, so I have to go. And if I have money to get high, I might not have that willingness. So if there's a way to get from the day that a person asks for help to get them here and involved in treatment, the better. And again, it's very frustrating on our side too. Last week I had a friend relapse, come downtown, get robbed, get her leg broken in 3 places. The next day I had to bury my roommate because he overdosed. And the night that I returned from the funeral, I have a friend who committed suicide because of the depression from addiction. So I mean, we're losing people too, but we still have to, continue to be positive, to have hope for the next man, and just continue to have faith that we do make a difference one life at a time, and we want a bigger recognition. We want to see the problem diminish, but if you focus on the smaller picture, if you've helped one person, then you legitimately have helped the world. So I don't know. I wasn't prepared to speak, so I don't have anything.
I would like to correct Ryan on one thing, though. You didn't just get your life together and blend in society. You guys are making a difference every day. Every time you come down and give hope to a patient, you're making a difference. So I think Kat is, I love our treatment program here because we have excellent medical care, we have excellent clinical care, and then we also have the bridge to the recovery community. So, we're covering all bases, and it's not just treatment, see you, good luck with that. It's treatment, what do you need next? And here's someone to hold your hand and walk with you on that journey.
Barb, could you share the fact that in Ohio now with Medicaid, your peer counselors, after they get educated, become, I guess they're certified counselors, and you can charge for their services, and in turn you can pay them for counseling?
Well, we're still working through that, but yes, that's a possibility now. There is a state certification for peer recovery supporters, which is a Medicaid billable service. I don't know where we are on adding to that, but right now I'm the only, I am state certified, and then the rest of our mentors are volunteers at this point.
God bless. Well, again, how about a round of applause for the Thank you so much. Thanks for sharing. Oh, unreal. Thank you. All right. Great. Well, Rob, if you'd come on up, and the rest of the last panel members come on up and have a chair. But Rob, you had an offer to make. I wanted to share with the room about opportunities for ride-along, all right? Tell us a little about who you are and how folks in this room might be able to ride along.
Certainly. My name is Robert Leininger. I'm the fire chief of Springfield Township. I'm also the current president of the Hamilton County Fire Chiefs Association. I see some familiar faces in here, which is great, but what I'm really excited about is to see new faces. That means that you're interested in making a difference in this world. These type of stories are just amazing, aren't they? And the gentleman who said compassion fatigue, I don't know if I totally agree with that, because we see so much. It's not just the unfortunate occurrence of an overdose, but we see all different types of difficult situations. You know, whether or not it's a senior suffering from depression, we see a lot of depression and things going on, and a lot of different dynamics going on in communities. So it's a lot of different things. But for the first responders in this room, I think they'll probably all agree with us. We find strength in our brotherhood. We find strength in meetings like this. You all are people that want to make a difference. You're going to change the world because you're the ones that have the energy, the excitement, and the willingness to put in the time and the effort to change things. And maybe it's just a little bit at a time, but it's going to be a change. Larry was instrumental in changing some legislation 5 years ago, actually 4 years ago, and getting the scope of practice changed for paramedics.
Thanks to then State Senator, now State Representative
Yes.
Bill Sykes.
Yes. And it doesn't sound like much, but that little change opened the door for a lot of opportunity to make a difference in this world. And I'm talking about community paramedicine. Community paramedicine, before, if you're a paramedic, the only way that we could really help you is if there was a 911 call. And we would respond with lights and sirens, and then we had to work within our scope of practice. But they changed the word in our scope to now say an emergency or non-emergency care. So that non-emergency means now that we can go out in the community, we can help people that have chronic disease instead of an acute emergency situation. Now we can be proactive, we can be patient advocates, and we can open the door to so many different resources out there. And we are blessed. We are resource rich in Ohio, and actually even Southwest Ohio here specifically. I know some of you are beyond our Hamilton County borders, but we are rich. But the key is that people don't understand that we have these resources. So what we've done in our community is we've become an advocate for our residents, or for those that need it, and also we are a referral agency. So if somebody needs Meals on Wheels, that doesn't sound like much, but we don't provide that through the fire department. But I know I can pick up the phone and I can call Council on Aging, and bam, I get a case manager, bam, they got Meals on Wheels. If somebody needs transportation to get to some place to go to their doctor's office, I can pick up the phone, call Council on Aging, various agencies, everything from people working cooperatively to you name it. And what we did is we developed a kind of a menu. Think about it, if you go into the restaurant, what's the first thing you want to do? You open the menu. What do I want today? Well, that's basically our approach. We went in for these people that needed various things, and we said, okay, what is your need? And we opened up the menu, and we said, okay, we have somebody that's a frequent flyer. We're there once a week because the lady falls. Well, when we're inside of her house, we realized there's a lot of obstacles in her house. Her house needs to be cleaned up. She needs grab rails in the bathroom. She might need handrails on her steps. So where do you get those? Well, we pick up our menu. We go down. People working cooperatively as an agency that can come out, and they'll build those things for free. And boom, that situation's taken care of. So that's what we've done with our community paramedicine. And what you're talking about today, and I like the conversation about the opiates, that's just one part of it. Because before, we couldn't really get involved in the post-care of an opiate or overdose. Now we can. Now we are involved in what they call QRTs, quick response teams. So we can get involved in the post-care and referral and follow-up to get people into the right resources. Now, for me specifically, Springfield Township, we're a population of 38,000 people, about 18 square miles. My neighbor to the west of me is Colerain Township. It is the largest township in Ohio. They've got 60,000 people. They see a lot more overdoses than I do. But they also were the ones that initiated the QRT. And so I looked at that in my community and I said, do I want to offer that? Do I want to offer a QRT? Well, I decided not to because they're already doing the research. They're doing the proof of concept. They're doing the measurable outcomes of that particular service. So I opted not to do that. I know that I can call them if I have a specific need and they would come and help me, but I decided to do something different. My CP program in Springfield Township focuses on mental health. We did a needs assessment, and we have a lot more people with mental health issues than overdose issues. Not that they're not important. We were just looking at the quantity. How could we influence the most people in our community? And we identified mental health. And we did that through the health department. They do what's called well, basically it's a needs assessment, but there's an acronym that they use. But they looked at the demographic, they looked at a lot of different factors, and they found out that we have an aging population that suffer a lot of anxieties, depression, and we're also seeing that more in the younger people today as well. You know, when you're a senior and you get up in the ages where, you know, your kids are gone and this kind of stuff, and they're living all around the country, and you turn on the TV or whatever, and there's very little positive anymore that you see, it beats you down. So you can kind of understand that, but it's the young people. I mean, we're in the elementary schools now with psych emergencies and depression and anxieties in high schools. Man, that's sad. But so we've decided to focus our community paramedicine program on mental health. Now, with that mental health component is also social services. When we started our program, Larry, can I go ahead and
Absolutely.
And go ahead and explain?
Absolutely.
Well, last year we applied for a grant through TriHealth, a healthcare organization. They have a group that's called the Bethesda Inc. that is a foundation, and I applied for a $200,000 grant to develop a proof of concept. Can community paramedicine make a difference in your community? Well, Larry and I, 4 years ago, had this idea, this big, a lot of people had this idea of how they could get out into the community and use paramedics, use the fire departments to go out and make a difference in your community, other than just a 911 response. So with that, I wanted to do it. Let's go do it. Well, you just can't just do it. We live in a world today of performance measurement and outcomes. So before they give you money, they want a proof that what you're saying will have positive outcomes. So I went to the Bethesda Inc. board, made a presentation, told them what I wanted to do, and they were gracious enough to give me $200,000. So with that, I put a group of people together, doctors, attorneys, medical professionals, representatives from Council on Aging, people working cooperatively, drug overdose resources. A lot of these people sitting around the room, and we started into the process. First process is needs assessment. What does your community need? How do you know? How do you know? Well, you probably look at your 911 responses, and the demographics are there, and the statistics are there, but you have to reach out and get them. So do you get them from the police? Do you get them from do you get them from the health department? Where do you get them? There's agencies out there that will help you with the numbers. So you start with the number crunching. Then you focus on what your issue is and make that decision. Then once you're focused and you're ready to go, then the work begins. We looked at the amount of mental health needs. We looked at the impact. Should we have social services? Should we focus more on that? Or should we focus more on overdoses? Should we focus more on certain acute type situations that are going on? So we focused on the mental health component. Then we're like, little things, how do you get in? Once you identify these people, how do you find them? Okay, I've got a mental health issue in my community. How do I know who has mental health issues? How do I get there? So we first have to decide what's our criteria. So we used 911 responses. So when there's a 911 call and my paramedics go out to the house, they evaluate the dynamic that's going on. It might just be an acute issue that we can take them to the hospital, or there might be other things there. They observe their environment, they see what's going on, and maybe they realize that we have this elderly female that the husband has passed away. She can't take care of her house. She's living in poor conditions. She doesn't have food in her refrigerator. And there's just a lot of things going on there. She needs help, period. So at that point, my paramedics make a referral to my community paramedic. That community paramedic then meets with a committee, a CP committee that I've got within the department. They identify, yes, we want to go out and help Mrs. Jones. So at that point, we contact Mrs. Jones. That's also a problem because a lot of times, who were the gentleman that spoke here and said they don't have a phone? A lot of seniors don't have phones, or they are suspicious of the call. So you call them and you want to say, "Hi, my name's Rob Leininger. I'm with Springfield Township. We'd like to help you today." What's the first thing they're going to do? Why are you calling me? What? They think there's a scam. They think there's something going on. So just developing that trust and just getting your foot in the door was a huge, huge obstacle that we had to overcome. And we spent a lot of time during that proof of concept process to develop how can we just get our foot in the door and help these people. Once we gained access to them, oh, it was wonderful. What a gratifying thing to do. And the people were so appreciative. The advantage that the fire department has is they already kind of have that trust with us. So not so much the police. And you can kind of, and not to throw my brothers in blue under the bus or under the police car. Don't mean that. My son's a police officer. But it's just something that's kind of comes with the fire service. They trust us. So we leverage that trust to allow us to get into the door, have those conversations, and then really determine what they need. One of the things that we focused on as well is frequent flyers. We have certain individuals that call us once a week, 2 times a week, 3 times a week, 20 times in a month. What is going on? So we identified those people, and with the intervention of community paramedicine, we got into it. We figured what is going on with this individual. And we tried to bring the resources together to help them. In a lot of cases, it was just something as simple as, I can't get to the doctor. I can't get to the pharmacy to fill my prescription. So I know that if I call and say, I'm having trouble breathing, you'll take me to the hospital. And they'll give me a new script. That's all they wanted. So they're playing the game. So you have to work through that. So we identified that. So the frequent flyers. And we've made a difference in frequent flyers. And we've reduced those numbers. That's a positive outcome. And that also ties into, what did I just mention? Trips to the ER. That gets the attention of who? The government. The government, abuse of the system, healthcare costs in our world today. They've looked at, when we take somebody to the hospital, average cost of an ambulance ride, we're just going to round it off, say $1,000. My cost. I'm going to charge you $1,000. You walk into the ER right away. By the time that they do triage, they look at you, they give you a script, and they send you on your way, $4,000. So right there, the insurance company is going to get billed $5,000 just from that 911 call. If we can be proactive and spend time with that individual and get them to the right resources that they need, that is avoiding unnecessary health care costs. And that is huge. It's our time as well, because we want to maximize our time and effort too. We want those results. We want good results.
And Rob, I think that's what's driving the federal government,
Yes.
HHS.
Correct. And Larry has more on that as well. The federal government is finally listening to us, and they're willing to give us monies now for treating people in the home. Now, they talk about an opioid epidemic crisis. Well, there's a lot of those out there. I mean, that they use those terms to get our attention, and it is. I agree, it is, and it's sad. Do you know how many diabetics we got out there that call us constantly because their blood sugar is out of whack, and we take them to the hospital, when we could treat them in the home, stabilize their blood sugar, get them what they need, and avoid that $5,000 cost just by treating them in the home. So there's a lot of different things that we can do through our scope of practice as a paramedic that can avoid unnecessary costs and, more importantly, influence positive outcomes. It all comes down to helping people have a quality of life in your community, and that's our goal.
Wow. Have a round of applause.
He's my partner right here, man. He's my partner.
All right, come on. This is a tough act to follow.
I know. I don't even know if I can beat that. I'm Amber Antoni, and my role is a little bit different in community partnerships. I'm actually the regional healthcare coordinator and the director for emergency and disaster preparedness in Southwest Ohio. So I partner with the hospitals and all of the EMS departments and lots of other community partners. So Red Cross, Hawksworth, the Fusion Center, anyone basically involved in any level of emergency preparedness. We work with some funding from the state of Ohio to purchase items and practice our capabilities together as a region. Recently, we've gotten lots more participation from EMS departments, and that's one of the reasons I'm talking to you guys is you don't have a disaster without EMS and fire and police response.
Yeah.
It's not just the
I can tell a
hospitals.
war story. I asked Amber if she could be one of our last speakers because I wanted her to hear from hospital systems in Indiana, Columbus, what have you, and about the amazing partnerships. And she says, "Oh, now I know what you're up to."
Yeah, so we have an amazing
There's an
partnership.
opportunity.
Yeah, so we have amazing partnerships. We actually do have some partnerships in northern Kentucky and some Indiana as well, because we kind of share borders. So we work together, do exercises, and kind of basically prepare for emergencies both inside the hospital and then outside the hospitals. I don't know what else. That's what I do.
Yeah, and so share with you a vision. How, we heard, for example, from J.D. Postage. Were you here when he was presenting in Mount Carmel Hospital and their partnership? And we've heard from Paul Miller and their relationship with their hospital. How can we get some of our local hospitals partnering with the fire service?
So I think it's bringing them all to the table and having a group discussion. So at the Health Collaborative, which is where I'm housed, we actually do bring all those hospital systems together, the big six, and then also all of our what we call CMS partners. So all the nursing homes, the dialysis centers, home health agencies, we all actually meet together on several levels. So I work with them on different levels other than just the emergency preparedness. We also work with accreditation. So they actually come together and share all their deepest, darkest secrets in a neutral ground about what they were surveyed on, what they did well, what they did poorly, and share with each other like, hey, watch out for this, watch out for that, try this, to actually help each other be better. So we already do some of those partnerships with competing hospitals, so I don't foresee bringing them together to work on something as wonderful as paramedicine as a challenge.
No.
I think it's just bringing the right stakeholders to the table and sharing the benefits to them of what this really does for our community and how it improves healthcare for everyone.
Wow, it's kind of like Ron pitching to Tri-Health's foundation, because every hospital has a foundation of givers, so it's tapping in. Wow. All right, thank you very much. I appreciate it. Yeah, we're on a roll here, right? Yeah. Thank you so much.
Okay, so I have a presentation, but I'll just kind of scrap that for the sake of time.
Yeah, I've got everybody's PowerPoints, so each one sent me an hour's worth of presentations. All right, and we're down to 10 minutes. If you send me an email, I'll send you whatever PowerPoints you'd like, okay? All of them. Yeah, all right, just send me an email. Go for
So
it.
I just kind of want to, well, first of all, I'm Angie Clark. I'm a professor in the College of Nursing at the University of Cincinnati.
And the last time you addressed this class,
That's right. I was in Singapore.
Singapore.
That's right. So,
Talk about a connection.
Yeah, so I'm happy to be here, and I just want to start off by saying I appreciate everybody's service And I appreciate everybody's dedication to their recovery because I feel like it takes all of us to really be working together. I've been coming to the CAT house, so the year after Mike started, so 9 years, I started taking psych mental health students here. And I noticed when I was taking my students here, they had like a different attitude that I wasn't used to with nursing students. It was kind of more like, oh man, what are we gonna do? What are we gonna do? This is a choice. And I started to get a little kind of annoyed, and that's why I went into this area of research where I thought, and this was before the big argument about this is a chronic disease, this isn't a choice, okay? So this was way back in 2011, and so this started to kind of come to fruition, and I thought, you know, I really want to make a career of this because what I found when I had patients here, they were the most gracious patients and clients, and I've attended a lot of the 12-week aftercare graduations, and getting up and hearing what these people in recovery have to say and sharing their story just really made an impact for me. And I had some of my students start coming to these graduations, and it changes the way we practice as providers. It definitely changes the way that I think about my patients when they leave or when we discharge or when I teach my students about discharging patients. In 2005, when I was a brand new nurse and I started sending my patients home, I was in respiratory step down. So people would come in and we would just send them home with loads of medications, and I'd have maybe 5 minutes to do discharge teaching. I'd say, take that, but don't take it with alcohol, right? And then I see that person the next week in the hospital, and it just started to change the way I practiced, so I felt very compelled to go into this area of research. So I kind of want to speak to, I'm sorry, what's your name? Brenda.
I'm sorry.
And Terrence, because you guys had questions earlier, what are we doing for people on the backside? And I want to kind of discuss that. So I'm going to talk a little bit about ESPER, which is the research I'm currently doing that's state funded. But before I get into that, we recently conducted focus groups because we wanted to know what people who weren't in recovery needed so they could manage recovery, right? We know that this disease is chronic, progressive, and if we don't do something, it's going to be fatal, right? So we had focus groups in the jail in a rural county, and we did them for a couple days, and listening to what people said, and they said, I'm evolving north, right? I know everybody in the community. If I'm going from the jail to home, there's 12 places I can stop to get drugs on my way home. I can't be clean, I hate to use that word, but clean here, right? And then go there, try and get home because I'm gonna stop on the way. I need more help. And this is people who've been in the jail for over a month, right? So they are completely free of a substance. So we thought, okay, well if we could wave a magic wand, this was our question. What would you want? And the ideas are amazing, right? It said, I need something out when I get out of here. I need a plan. I need a place to go. We said, how many of you have driver's license? Nobody, right? Nobody. If you don't have a license, if you don't have an address, you can't get Medicaid, right? So we're starting to piece this all together, and then they'd say, okay, so we'd say, well, there's this place in the county that you could go to for medication-assisted treatment, and they'd say, yeah, but I can't get in there because I haven't detoxed, right? So there's all these things that are kind of holding it up. So we said, all right, this is what we need to do. We need to get a grant. We need to develop sober housing. We need to help people transition. This is a chronic disease, so we have to treat it like a chronic disease. So we have to help them transition from jail to short-term, like detox or intensive outpatient or inpatient, depending on what we can get them into. But before we do that, we got to get them set up for Medicaid so we can get this covered. Before we do that, we got to get a license. Right. We got to talk to the health department and say, can we use your address so we can get stuff sent here because people don't have a place to go, right? So we're kind of starting there, and then we see that there's these services in the community, and we're trying to kind of be the bridge to help access those other services for people. And sometimes that means me calling Mike and saying, hey, I have somebody who is working through recovery. I need to find out where I can send them from a different county to get here because there's not a non-faith-based option there. And they're on medication-assisted treatment, so they can't go to sober living. So what do we do about it? So then I'm on the phone with people in sober living, and I'm saying, okay, well, if we do injections, can we have people there, right? You know, and the other thing that came up, and I appreciate you saying this, is that there weren't groups for people to go to. There's no 12-step programs because, well, it's hard because some people operating in the program believe in abstinence only, and some don't. And the thing is there's not a one-size-fits-all for recovery, and we have to understand that as providers and as a community. So kind of helping to build that. So I appreciate your guys' questions on that, and we are working on it, and we will continue to work on it. We're also working on getting people jobs because that's a huge part of recovery, and helping them pay bills again, establishing credit, working on a resume, practicing interviewing. So these are things that we're really working hard on in rural counties, and we're hoping to do that here, yes.
You're right on it, like, because we don't just have meetings. Like, NA is great, I'll never say that bad about it. They've been saying for millions of people for years. However, you go to a meeting, sit for an hour, if you're homeless or whatever, you come out that same hour the same way. So I didn't want the traditional, I don't want, my MAT group, I didn't want that. So we created 5 pillars of long-term recovery. And it's housing, stable, safe housing, not just housing. Because I've seen housing do people bad, because people are home and you're not comfortable. You know, when you're going back to the streets. So safe and stable housing, financial awareness. We just automatically think people know how to open a bank account.
Nope.
When I get in the group, they don't want house, so they take their check cash, take $17 out of $150, do that every week. So then I did health and wellness, because people out there is also just running not eat right. So what I did after that, I did a family unification program. And what else? We also have the employment. And when I learned, because I took it to the streets, they got temporary services who get paid every day. And you got drug dealers that give you credit before you leave, and then take your check when you get back. So they need a career and trade. And you got the same idea, but guess what's different? The people won't follow you because they don't. No, our first thing is to say, you don't look like me, you don't look like me. It's to disqualify you. You know, and that's not no bad thing to you guys, you just want to help. But that's what people do. So I don't want to reinvent the wheel, I just want to be able to hold their hand. But from the beginning, not peer support from the end. You want to get, if you overdose or something, I got you right here. They can tell you what the treatment is and take care of the barriers. And then when you go, stay in contact. That way when you get out, that relationship is there and you can walk into the resources. Because it ain't just driver's license, it's opiates take everything, birth certificate, social security card. You gotta start from scratch. And I seen that, you know, and it was like, I'm gonna keep advocating, I'm gonna fight to the end. This guy got the purpose, I'm going. And this is my results. I mean, I love these. I would fight for them to the end. You know, and they say, oh, you substitute one for another. I said, we've been doing that. I can't help sugar, I gotta get split. I can't eat hamburger, I gotta get turkey. So people can substitute one for another who said it was bad. You know,
No, I appreciate it. I also want to add, we have peer navigators in this grant because we know that that is the key, right? So we definitely have that in there, and that's important. And then what we're also working on is, because it's rural, we're trying to say, how do we get these people training? Because we don't want somebody who's not qualified and then they're both going to have problems. Right? We want to make sure that this is quality and we're not setting people up for failure. So I appreciate you saying that. Yes, that's absolutely a big part of it.
Special training. You know,
there is.
Like,
5 days.
That's right. And even in addition to that, because I'm a high peer specialist, I'm a CPCA, I got a bachelor's degree, I got all that. But I'm in a box, 9 to 5, billable. If I see somebody down the street at 7 o'clock, I can't give them a ride because it's unethical, there's boundaries. Recovery and relapse happens in the community, in the streets. Not 9 to 5, but it's not their fault, it's just the way Medicaid is set up, it's billable. So my whole job was like, hey, every time you talk to somebody, write down your time and bill them. I'm like, no, I love this person, I'm not about to charge them $945. But that's how it is. And that's just what they know. And that's okay, that's what they know, but we're going to change that.
Well, I want to hear more about it, So real quick thing, because I know there's other people rapping. The other thing that we're doing is screening, brief intervention, referral to treatment, which is huge. So we're training providers, students who are soon to be providers, and even people in the community, teachers, to do brief screenings and interventions, meet people where they're at and try and get them into treatment. And that doesn't mean saying, oh, hey, call this person. That actually means going with them, helping them, signing them up. That's the big difference. That's kind of been our downfall in healthcare as a provider. I'm willing to say it. So anyway, with that, I appreciate everybody's support. Thank you.
All right. Promise to get you out on time. 1 second Marketing 101. Take a look at the arrow. What our plan is for starting this fall is, rather than a 3-day residency where a fire department would have to pay for their medic to be off duty for 3 days, we're going to go to a model of a 1-day residency. Hopefully with Mike, we'll do it here physically 1 day, and then the rest of the course will be online. Okay, so that's our future model, and that fall semester starts August 26th. And I have not yet selected the day, but the concept is we'll have a day together here, all right, and then go online, all right? And right there's a business card right on the front, all right? Send me an email, we'll get you the PowerPoints, and we'll rock and roll, all right? And thank you. Oh my gosh, we hadn't met before, so come on up. I didn't know you were here. Yeah, I met your boss. God bless you. So, there is time.
Thanks, Mr. Bennett.
Imagine this. Here I am at my church, and it's an adult ed session, and it's about the Hamilton County Library. And one of the slides says drug addiction. I'm like, what? Tell us the connection. We hadn't met before.
Oh, sure.
So thank
yeah,
you.
thank you for your time.
Sure.
I won't keep you. Like he said, he's got my slides, and I have a business card, so I can follow up with you afterward. But we're wrapping up the day talking about partnerships. So just encouraging you to think of your public library as a potential partner. If you're here in Hamilton County, the Public Library of Cincinnati and Hamilton County, where I work, has 41 locations. We have 16 in the city and the rest out in the county. So we have, we're embedded in the community. We have lots of locations for you to think about. Sort of just in terms of general partnership opportunities, besides, at all of these 41 locations, we have free meeting room space, if that's something that you might need. We have capacity to support you. We have over 800 staff working in the library and about 400 volunteers. We also foster connections because we're in the community, because we serve cradle to grave, because we serve the public, we're publicly funded. We can connect you to partners, experts, resources, education opportunities for your clients or for your colleagues.
So if a substance abuse person needs to be connected, I'm trying to get the connection. What happens?
Yeah, well, so we can support you in the work that you do, and we can also support the community members that you're reaching, either as first responders or in other roles. So what we're doing right now is sort of both sides of the coin, right? So prevention and awareness, trying to reduce stigma of addiction through workshops. We did a community forum last month about opioid addiction and had about 80 folks show up. So we have those kinds of opportunities. And then when you're thinking about recovery, which we're just talking a lot about, I mean, some folks need a place to go. So the library is a place to go. We provide sort of those what's next services. So we can help people write resumes. We can help people with practice tests for certain jobs. English as a second language. It could just be helping someone not be so socially isolated and get out and attend a workshop or interact with other folks in the community. It is a safe space. It's a neutral space. There's no judgment at the library. Whatever it is you need to do or want to do, you're welcome to do that there. So that's the recovery piece as well. What other points should I hit? So we do have some partnerships going. We are especially at the main library, where we see a lot of the addiction issues occurring. We definitely work closely with the police department and first responders. They've been super supportive for us, so that's been really helpful. We also work with DCI and 3CDC in terms of having them come in and engage with our customers who might be ready to seek help or that kind of thing, just generally be a presence. Hamilton County is somebody we've worked with as well. Prevention First, Talbert House, those kinds of folks were at our forum last month. Talbert House also provided training to our staff because library staff need to be able to be informed and prepared to support the community. So we work with those folks. Also, the University of Cincinnati, Claudia is over there. So we're working with Claudia around the sort of reducing stigma, increasing awareness, encouraging action.
In fact, Claudia, come on up if you will.
Yeah.
Right?
So they're putting together an exhibit
Yeah.
that we will start with at the main library and move around the community. Yes. All right.
Look at this.
So there's a good segue, and I'll
Stay.
give you my business card, and if you have any questions, I can help you out.
Nice to see you.
Yeah, you too.
So briefly, I'm a year and a half old in Cincinnati. Before this, I was in Providence, Rhode Island, and I launched it with a partner at Brown University, Nalox Box, and we installed 55 smart cabinets in the Providence area to really, reduce the numbers of overdoses. It was a pilot. But it was an amazing pilot because what we learned is that we need to be more bottom up with the issue and really empower people, for anyone, a bystander, to become a first responder. So when I came to the University of Cincinnati, I happened to be attending an event sponsored by AIGA, the Graphics Design Society, Design for Good, and I met Carol Baden, and I was shocked.
Attorney General's office.
Yes, thank you. So I was like shocked with the numbers that she kind of like shared that day, like 50, 80 people overdose a week. I'm like, what? This is insane. So I couldn't really stop working on the projects, and I put together a team of graduate students at the Masters of Design at the College of DAAP, Design, Architecture, and Planning, at the University of Cincinnati, and started working on version 2.0 that nowadays we call Anti-OD. We are scheduled to deploy around the same time that we're going to be setting up an exhibition. And what is Anti-OD is a community-based program that provides the training, the tools, the ingredients to save a life. And we have been designing a dispensing system that has some technologies that allows you to, call for 911, hook you, in the system, and provide multiple multimedia means of absorbing information, how to save a life at the moment, from print to text-based, support, etc. So
and your magic box.
Well, it's not a box. It's not a box. But it's a dispensing unit that has single kits that you can remove. Yes, I will. In a minute. So, okay. Okay, so it looks like this, the dispensing unit. There's going to be some text in here, but this is a prototype. And we have pocket-size information, and here is the interactive component. And in addition, let me show you. Okay, can I get some help? There we go.
Oh, here we go. Here's a photo op. Come on, here we go.
You speak
up. Everybody smile.
So this is the kit, and there's going to be 2 per dispensing unit, and we are launching 36 units for now in different areas of downtown Cincinnati, around the library. And when you remove it, we can remove it now. Okay. It will, pop up the training like 1, 2, 3, 4. This is what you need to do. And call 911, and then you. I'm not going to do it because it's but you tear this and you get the ingredients, and it's a bilingual kit that has all the instructions.
What's in the kit?
In the kit, there are 2 doses of Narcan,
Okay.
1 CPR disposable mask, a pair of gloves, and the Narcan information sheet.
So that person's ready to beat your ass once you do that. So what you do? What you suggest we do after that?
What do you mean?
After Narcan. That's what she's trying to say.
Let me hear.
They might not know. Narcan, see, I took it to the street.
Yes.
You can't go to where Al can go. Don't go, because I didn't want to. But what they called it is double down. So after you Narcan and they're upset, you messed up their high. So on the street, they call it double down. That means they got to take one to get over the naloxone, then the next one they get high. But that's when the fatality happens. You see, so we build so many harm reductions, but we got to have in place. But let's continue to do the recovery piece. Treatment is not recovery. Harm reduction is not recovery.
I understand.
If we have recovery, we have less systems. of Narcan. You know, the millions are down there, but then after the Narcan, after the treatment, they go to the street.
I know.
And nothing happens, so guess what happens? They start back over.
I totally understand your point.
Yeah, that's all
My
I'm
project focuses on making Narcan available.
Oh, okay.
For now, there are many phases of this project. That for now, this aspect of anti-OD is to providing access to Narcan, because even though there is a lot of efforts available, we still are not reaching out to everyone, and especially we are not reaching to everyone because we are not educating the public, and we are not doing a good job in reducing the stigma and empowering people to say you can save a life. So I'm trying to kind of like work with those, parameters. But I agree with you, sir. I agree with you. Other aspects of the project. Thank you for your comment.
Now a round of applause.
All right.
Good. All right.
Can I just say one more thing?
Sure, of course.
So, as part of the library exhibition, we are trying to really partner with people and portray real stories. So if you have, if you want to partner with us and help us distribute resources, information, stories, please contact me. I'm going to leave my business cards in here. I would love to partner with everyone. So far, the team of anti-OD is DCI, 3CDC, Cincinnati Bell, UC, whatever, like many people are part of this, but I cannot do this alone. So let's honor the name of this seminar, Partnerships.
Yes.
Okay? And please contact me and let's, work together on this.
Yep.
Okay?
Thank you very much. And
But-
again,
We're going to start with the main library. There's two phases of this project. The main, we're going to do an exhibition from May 6th to June 15th as kind of like an opening. But later on, from August on, probably, that's to be discussed. So this is just tentative. We're going to be launching many kind of like modules, interactive exhibitions across public libraries that we're going to be rotating and kind of like working with the information and hopefully culminate with a bigger exhibition a year later or something like that. Plans, not facts, but that's what we have discussed. For sure, May 6th to June 15th, that's happening.
I love it. And, all right. And I have a list of all speakers and contact information. So even if you don't want PowerPoints, send me your request and I'll get it right back to you. God bless you. Thank you.
All right.
Safe travels.